We're going to get started. Good morning, everyone. We're going to go ahead and get started. I think we're ready to go. All right, all systems go back there. Cody, are we good?
We're ready, thank you.
Thank you so much. Good morning, everyone, and welcome to the meeting of the Mental Health Services Oversight and Accountability Commission. My name is Mara Madrigal Weiss, and I am the chair of the commission. I want to thank you for attending today's meeting. As our January 25th commission meeting, we approved the commission's strategic plan for 2024 through 2027. Cody, can you please bring up the strategic goals slide? This slide represents the goals of the Commission's new strategic plan, which continues our commitment to advancing the Commission's vision of well-being for all Californians. While the content of our meetings often touches many of the strategic plan goals, today we will discuss the implementation of Prop 1 and how the Commission can support the state's efforts around behavioral health reform. These topics are directly connected to our strategic plan goals of championing vision into action and relentlessly driving expectations. You'll all notice that many agenda items have icons next to the titles. These icons represent the strategic plan goals associated with each agenda item. Our intent is to clearly link agenda items in our meetings with the strategic plan. Thank you, Cody. Now we will take roll and establish quorum. Maureen, can you please take the roll? You're still on mute, Maureen.
Yes. Commissioner Bontrager,
Here.
Commissioner Brown,
Here.
Commissioner Bunch,
Here.
Commissioner Carrillo, Commissioner Carnavale,
Here.
Commissioner Chambers,
Present.
Commissioner Chen,
Present.
Commissioner Cortese, Commissioner Danovich,
Here.
Commissioner Gordon,
Here.
Commissioner Mitchell, Commissioner Robinson,
Here.
Commissioner Rolette,
Present.
Vice Chair Alvarez,
Here.
Chair Madrigal Weiss.
Here.
Madam Chair, we have a quorum.
Thank you, Maureen. Moving on to announcements and updates. I would like to begin this morning's announcements by acknowledging former Commission Chair John Boyd. We would like to honor John with a resolution acknowledging all he has done for the Commission. Unfortunately, he could not join us this morning, so we will present the resolution in absentia and deliver it to him in the next coming days. John Boyd was appointed to the Commission by Jerry Brown in 2013 and served for 10 years, including as Vice Chair in 2017 and Chair in 2018. John brought to the Commission the perspective of a large employer serving as a senior executive in behavioral health for some of the largest healthcare providers in the country. Commissioner Boyd championed critical projects of the Commission, including the inaugural California Innovation Summit, the Commission's Youth Innovation Project, and the documentary Hiding in Plain Sight, which is highlighted in the country's youth mental health, which highlights the country's youth mental health crisis. Throughout his tenure, Commissioner Boyd shaped nearly $500 million in innovation investments and grant-making in mental health, elevated community voices, particularly the voices of youth and young adults, and inspired renewed attention on crisis services, prevention and early intervention, and anti-stigma, which has indelibly shaped California's mental health system. Today, we express our gratitude to Commissioner Boyd for his contributions to advancing the well-being of all Californians and for the lasting impact his persistent leadership and humanity have had and will continue to have on the well-being of all Californians. So in acknowledge of that, I'd like to just applaud John Boyd. Thank you. Moving on, there was a site visit in Butte County. Full-service partnerships are a core strategy for supporting Californians with serious mental illness, including approximately 12,000 children and 8,000 transitional age youth. To better understand the experiences of youth, FSP partners, and their families, the Commission conducted a site visit to Butte County's Youth Intensive Program, often called YIP. FSP, well, they did this yesterday. The Youth Intensive Program serves eligible FSP clients who require assistance in managing their mental health conditions. The resources offered by YIP are centered around the behavioral health needs of youth and families and are cross-integrated with local entities to enable easy access to care and allow gradual transitions to lower tiers of care. Youth who have utilized services from YIP have experienced fewer hospitalizations, home displacements, and juvenile justice system involvement. I would like to invite any of the commissioners who attended yesterday's visit to share a little bit about the experience. Please, Commissioner Brown.
Yes, Madam Chair, I had the opportunity to attend yesterday with a number of the staff who also were there, and we had a very nice tour of the facilities that they have. They're kind of in a transition mode in terms of the facilities, but they're in kind of a centralized behavioral health, public health campus that has a lot of adjacent buildings that are close by for services that are complementary to what they're doing. And it was, I think that my takeaway from it was that they are struggling, just like many counties are, most counties, I would say, that the number of cases, the number of staff to client ratio is large, but they're adapting and they're making good use of the resources that they do have. One of the things that really struck me and touched me was they have one peer support specialist who they have on staff, and she was there at a presentation with us. She was very engaging, very gregarious, very accommodating, and she was there not with a consumer, but with a consumer's grandfather, a guardian, who would bring this young boy into class, and who was, as a family member, struggling also with this boy's mental health issues and developmental issues. And he spoke very glowingly about how this peer counselor had actually been essentially a family support specialist to him and had actually really made the journey much easier for he and the rest of his family. So it was a testament, I think, to the fact that they are adapting. They're figuring it out. It's kind of an all hands on deck approach, and I think, unfortunately, that's an approach that a lot of counties in California are going to have to take. It's none of us have enough staff, none of us have enough resources, none of us have enough money. We have to figure out how can we best use those resources, and I think they're doing a pretty good job of that in Butte.
Yeah. Thank you, Commissioner Brown. I want to thank you for being there and thank the staff for putting together these visits. I think it's so important when we can get out there and really see what's going on in the communities. And again, just I think every time we talk about the peers being involved, how they can really lend themselves to the experiences of, tapping into grandparents and extended family members. They really do offer that great support. So thank you for that. And I want to thank, of course, Butte County for setting up this visit and sharing their experiences with us. The commission is growing, and we have new staff to welcome. At this time, I would like to invite Melissa Martin-Mollard, Kimberly Watkins, and Jigna Shah to the podium to introduce our newest staff members.
Thank you. Okay. Good morning, everyone. My name is Jigna Shah, and I'd like to welcome our newest staff member, Claire Salee, to the commission. So Claire brings with her extensive knowledge of the Mental Health Services Act and the behavioral health field. Her state experience includes working with the Department of Mental Health, the Department of Alcohol and Drug Programs, and the Department of Healthcare Services. Outside of state service, Claire has worked as a private consultant with many nonprofits, including the California Women's Mental Health Policy Council, the California branch of the National Alliance on Mental Illness, and the California Institute for Behavioral Health Services. Much of Claire's work experience has been in a training and technical assistance capacity, where she's liaised with counties and community partners on fiscal and programmatic policy. For the past several years, Claire has been working in hospice in both the hospital setting and in community-based settings. Claire lives in Sacramento with her wife, son, and dog, and they love going camping and going to baseball games. So welcome, Claire.
Hello, everyone. Please join me in giving a warm welcome. I'm Callie Clark. I'm standing in for Melissa, who is still traveling in. Please join me in giving a warm welcome to Boyoung Fan, who joins us as a Research Scientist 1 on the Research and Evaluation team. Boyoung brings a wealth of experience to the Commission. He holds a PhD in health psychology and clinical science from the City University of New York. He's both a clinical psychologist and an analytic researcher with 10 years of experience studying interventions for mental health conditions. As a postdoc, he worked at UC Davis in Dr. Julie Schweitzer's lab as a project manager, leading a government-funded project that developed a virtual reality intervention program to improve attention and behaviors in children with ADHD. We're delighted to have Boyoung with us, and please again, give him a warm welcome. Thank you.
And then we had one manager online. Kimberly, if you want to go ahead.
Yes, I'm Kimberly Watkins. I'm the HR manager, and I would like to welcome our newest staff member, Pamela Nelson. She started with the commission on April 15th as an executive assistant, retired annuitant. Her background includes 15 years as an executive assistant at Department of Healthcare Services. She worked for 19 years at Sac State University as a senior administrative assistant, and she will be assisting the commission with general office support. Please welcome her. Thank you.
Excellent. Thank you so much. So we welcome Claire, Boyoung, and Pamela. We look forward to working with you and learning more about your unique gifts as we tackle the work that we have ahead of us. All right. The February 22nd commission meeting recording is now available on our website. And I am happy to announce that the Commission's Client and Family Leadership Committee and the Cultural and Linguistic Competency Committee will reconvene in May. As the Commission's longest-standing committees, the CFLC and the CCLC have been fundamental in ensuring that the community voices and perspectives are reflected in its work. Under the leadership of Commissioner Chambers and Commission Vice Chair Alvarez, committees will now have an enhanced role in supporting the implementation of the Commission's strategic goals and objectives. To make the most of this transition, past CLCC and CFLC members have been invited to return and participate in 4 meetings between now and June 30th of 2025. The first meeting will take place virtually on May 8th from 3 to 5 p.m. This will be a joint meeting involving the CLCC and CFLC members to discuss committee goals and meeting dates. CLCC and CFLC, meetings will be scheduled separately for the remainder of the term. I would now like to invite Commission Vice Chair Alvarez and Commission Chair Chambers to say a few words about the new committee plans. Whoever would like to, well, please, Commissioner Chambers, if you'd like to start.
Yes, just want to thank
our committee and the staff for engaging us. And I want to encourage all of the members of both committees to get involved and engage as our mental health system transforms and we implement the commission's strategic plans. We want to support the commission's efforts and Californians' efforts, and the community is the most important in leading and driving that. So I just want to encourage everyone that's been involved to please engage, show up, so we can bring the peer voice and diverse communities together. Thank you.
Thank you, Commissioner Chambers. Vice Chair Alvarez.
Thank you, Chair Madrigal-Weiss. And I wholeheartedly agree with the comments of Commissioner Chambers. I want to deeply appreciate in advance the commitment and continued expertise that is lent from our committee members. I also want to acknowledge the opportunity we have with our new strategic plan and the fact that these committees are a formal structure that allows us to receive that valuable input and guidance from our community, from the diverse community perspective and family perspective, that really will strengthen implementation of this work for the next few years. With that strategic plan identified, I think we have a robust roadmap to think through together, and I'm looking forward to that opportunity. So similar to Commissioner Chambers, I encourage our current members to continue this commitment, to reach out with any questions that you may have, and thank you in advance for the continued time and expertise you will lend. Thank you.
Thank you. Thank you both. And we look forward to hearing more from our committees as the year progresses. In 2023, the Commission worked with the California Department of Aging to identify 2 programs, AgeWise and PEARLS, to receive our Mental Health Wellness Act funding to expand those programs. To continue our collaboration, the Department of Aging has extended an invitation for commissioners to attend the 2024 Master Plan for Aging Day of Action in Sacramento on October 8th. If you're interested in attending or would like more information, please connect with Tom Orrick. More information will be available as we get closer to that event. And finally, as many, if not all of you know, California is currently grappling with a fentanyl crisis among its youth. In response to this, the legislature has proposed various preventative measures, including permitting students to carry Narcan on campus. I've instructed Commission staff to monitor these measures and report back on their progress in the legislature. Given the alarming increase in overdose deaths, I look forward to hearing about the state's efforts to address this crisis. So at this time, that concludes announcements and updates. I want to once again welcome everyone again to today's meeting. The plan is to end around 4:30. Commissioners who are online, if you leave the teleconference meeting for any reason and decide to rejoin, please make sure to use the raise hand function so that the Commission staff can make you a co-host again. It is now time for Agenda Item 3, General Public Comment. This time is reserved for comments on items that are not on the agenda. I want to note that we have a small change to our public comment process. For individuals providing public comment on Zoom, you will see a small timer in the upper right-hand corner of your screen. This timer will let you know how much time you have left for public comment. If anyone is interested in making public comment regarding the announcements or other items, please make those during this general public comment time. If you have any technical questions, please contact Commission staff at 916-500-0577. At this time, I will ask Amariani to go over the public comment procedures.
All members of the public will have the opportunity to offer comment as described in the agenda. If you would like to comment on an agenda item, please wait until that agenda item starts. You may request to make public comment by clicking the raise hand icon on your computer or the app, or if calling in by phone, push *9. You will be placed in a queue to comment on that agenda item. When it's your turn to comment, the moderator will unmute your line and announce your name or the last 3 digits of your telephone number. When you are unmuted, we are able to hear you. We will do our best to take comments in the order they are received. Please note, once the public comment period for the agenda item starts, we will close the public comment queue, so please make requests to comment now. The moderator will insert the word last comment next to the commenter's name or number to identify the last public comment. Members of the public should be prepared to complete their comments within 3 minutes or less, depending on time constraints. When we have reached the end of your time, our staff will let you know, as well as the timer, but we will let you finish your thoughts. We don't mean to cut you off, but we do want to help everyone keep time. We truly appreciate your understanding with this process. Lastly, if there are any members of the public using translation technology, please notify the chair and at least twice the amount of time will be given to you during the public comment period. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. We do not have any in-room comments.
And do we,
Doesn't look like we have any online comments either.
okay. So unless,
Were there any final public comments? Okay, no, it looks like we have none.
so I'm going to say that's a first in about 8 years that I have been on this commission. Unless there's we're having technical difficulties, we are going to move on. And I'm serious about that. We'll come back if there was an issue. So we are moving on to agenda item number 4. Consider approval of minutes from the February 22nd, 2024 commission meeting. At this time, I would like to invite commissioners to offer comments or questions. I see none in the room. I also don't see any virtually. At this time, members of the public may request to make a public comment on agenda item 4 by clicking the raise hand button on your computer or the app, or if calling in by phone by pushing *9. Are there any public comments on Mariani? Please raise your hand now as the queue will be closing.
There are no public comments for this item.
All right, then I would like to move to invite a motion that the commission approves the February 22nd commission meeting minutes.
So moved.
Thank you, Commissioner Rolette. Do I have a second?
Second.
Thank you, Commissioner Robinson. We have a motion and a second to approve the February meeting minutes. Are there any additional questions or comments? There weren't any, so seeing none, I'm going to ask Maureen if you could please take roll.
Yes. Yes. Commissioner Bontrager,
Aye.
Commissioner Brown,
Abstain.
Commissioner Bunch,
Aye.
Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen,
Aye.
Commissioner Cortese, Commissioner Danovich,
Abstain.
Commissioner Danovich, Commissioner
Abstain.
Gordon,
Abstain.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Rolette,
Aye.
Vice Chair Alvarez,
Aye.
Chair Madrigal Weiss.
Aye.
The motion passes.
Thank you, Maureen. The commission will now move on to agenda item 5, Conflict of Interest Code. The commission will consider approving amendments to the MHSO AC Conflict of Interest Code, which will be filed with the Fair Political Practices Commission. We will hear from Lauren Quintero, Chief of Administrative Services at the commission. Lauren, please go ahead.
Thank you so much. Clicker. So, every 2 years, the California Fair and Political Practices Commission requires all state agencies to review their conflict of interest code and determine if any changes are necessary. A conflict of interest code specifies positions that are required to disclose economic interest on the Form 700. All you commissioners, we've been badgering you pretty much all of March to get them in, and you all did, so thank you. You're required to file it as well as all of the commission staff. The Conflict of Interest Code also assigns disclosure categories outlining the types of economic interests that you have to disclose on the Form 700. So our draft amendments that we are going to be putting forth, they remove some abolished and obsolete positions. That happens when CalHR maybe changes the name of staff counsel to attorney or something gets realigned. We add new positions that are new to the commission and reclassified positions. We've also this time tweaked the disclosure categories a little bit to reflect some of the changes that are happening as a result of Proposition 1. So we added a little bit about substance use disorder programs. So all that we need from you today is to vote on the draft amendments, which were in the packet. Also in the packet was an explanation of the changes in more detail than I'm giving right now. If everything is voted to proceed, we will work with the FPPC to initiate the 45-day public comment period. If during the public comment period we don't get any comments that require revisions, the Conflict of Interest Code will be approved and it will get filed with the Secretary of State. If revisions are needed, we will end up coming back to the Commission for approval and we would do a new 45-day public comment period. The new code will be effective 30 days after the Secretary of State endorses it. So I've got the proposed motion up on the screen. And if you have any questions, please let me know. Maureen is also on the line since she's actually the counsel and can answer legal questions. It's very quick, very just a practical, technical thing we have to do.
Thank you, Lauren. Thank you, Lauren. At this time, I would like to invite commissioners to offer any comments or questions regarding this item. I see none in the room, and I see no questions from our commissioners on Zoom. So it seems like something's standard practice. So this time I'm going to invite members of the public to request to make public comment on this agenda item by clicking the raise hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments? Amariani, please raise your hand now as the queue will be closing.
We currently have no public comments for this item.
Thank you. So at this point, I would ask then if we could have a motion from commissioners.
Move for the staff recommendation.
Thank you, Commissioner Brown. And a second.
Second.
Thank you, Commissioner Danovich. I would ask then, Maureen, we have a first and a second to accept staff recommendation on this. Can we take a vote?
All right. Commissioner Bontrager,
Aye.
Commissioner Brown,
Aye.
Commissioner Bunch,
Aye.
Commissioner Carnavale,
Aye.
Commissioner Carrillo, Commissioner Chambers,
Aye.
Commissioner Chen,
Aye.
Commissioner Cortese, Commissioner Danovich,
Aye.
Commissioner Gordon,
Aye.
Commissioner Mitchell, Commissioner Robinson,
Aye.
Commissioner Rolette. Vice Chair Alvarez,
Aye.
Chair Madrigal Weiss.
Aye.
The motion passes.
Thank you, Maureen. Thank you, Lauren. All right, we are going to move on to the next item on our agenda. Let's see. So we are ahead of schedule. We are going to move we're going to move up in the agenda because we have a guest speaker for agenda item 6. So we're going to, and they're not here yet. So we're going to move on to agenda number 9. And that is the budget. So, thank you. All right. Agenda number 9, spending plan update. The commission will hear budget updates and consider approval for expenditure plans associated with contracts for fiscal year 2023 through 2024. I'd like to welcome Norma Pate, Deputy Director of Administrative Services and Performance Management, to come up and present. Welcome, Norma. Hey.
Morning, everyone. A little early for our budget, but I'm ready.
I like it. Batter up. Here you go.
All right. All right. This is typically we don't present on the budget in April, but this month we wanted to present our expenditure update in hopes that we can get some of our contracts underway and encumbered before the end of the fiscal year so we don't face that end of the year rush. And so, but before I start with our budget, I just wanted to give a brief update on the state budget. As you may already know, Governor Newsom's predicting a $7.3 billion early action plan to address part of the deficit before the regular budget process later this spring. The governor is proposing budget cuts to some programs, and those programs primarily rely on revenue and borrowing. And then new revenue, a nearly $4 billion expansion on a tax on health insurance plans that allows the state to draw matching federal funds. And then internal borrowing, utilizing internal borrowing and funding delays and shifts for savings. Also looking at reserves and funding freeze, the plan will includes language to freeze one-time funding from past years, an agreement to tap into half of the state's reserves in the upcoming budget. We've been working closely with finance, and so far none of these budget cuts affect the commission or the Mental Health Services Act fund. And so these cuts at this time do not apply to us, but I will keep you updated as I find out more from finance. The governor also is encouraging state workers to return to the office at least 2 days a week. And recently we've notified our staff that we will be returning to the office at least 2 days a week, and then working hybrid schedules. And so that's expected to take place in June. And as far as our budget, this chart shows our updated expenditures and proposed adjustments that we're making to our budget that I'll be asking for your approval today. Under our personnel item, we've been, over the last several years, the commission has been successful with our request to increase our capacity. We now have approximately $9 million for staff, in addition to one-time funds for limited term staff to support our initiatives, create a secured IT environment to protect our data that we receive and ensure we're protected from IT threats, and of course our admin per team that provides support to the commissioners and staff. On our operating budget, we set aside approximately $2 million to support our operating budget, which includes our lease and ongoing costs like computers and different things that we need to be successful. And also our communications budget, we have about $600,000 set aside for our communication efforts. We have now 3 staff to help our chief of communication with our communication efforts, and we are planning to shift $64,000 to communications to help elevate our early psychosis work, and about $40,000 to help us elevate our learnings from our study on universal mental health screening of children and youth. It's really important that as we continue with our projects and our learnings, that we communicate this to the public and to the commission. And so we're increasing our budget for communications to help support that work. And under our innovation item, last year the commission approved $500,000 for an innovation summit, and we weren't able to reach a contract agreement to allocate these funds last year, and so we shifted those funds to this year, and we are in the process of negotiating an agreement for this work and plan to allocate these funds this fiscal year.
So just a brief update on that. In my line of business, sometimes we have to go slow to go fast. And this innovation idea was originally thought to involve a summit. And as we started studying it more, and we've had dozens and dozens of meetings on this, we realized that just holding a summit without doing a lot of work in advance of that would not result in transformative change. And so we've been meeting with lots of different organizations to understand what the best approaches are to this innovation. And I think we now are coming to the conclusion of a pretty good plan about how we want to lean into that. And I can go into more detail if anybody's interested, but I think we're now positioned to move forward and engage with some organizations to create a construct that will allow us to really unleash this idea of a partnership between the public and the private sector, which in a way is more relevant than ever when we're faced with this budget crisis that the state has. One of the best ways is to leverage other partnerships, and we have the advantage in California. We have the greatest innovation engine in the world in Silicon Valley, and the ability to connect them to the state needs and understand better in the behavioral health system how we can serve those needs through the mechanisms that Silicon Valley has, creates tremendous opportunity for both cost-effective approach and innovations that could add to the kind of transformational programs that the commission already stands up. So I think we're now ready to move forward with that, and this is the first step in that process.
Thank you, Commissioner.
Thank you.
All right, and then next is our research. Over the last several years, we've provided funding to UCSF to support our research and evaluation efforts. The contract is nearing the end, and the plan is to continue our partnership with UCSF and allocate $3.3 million over 3 years to support a research and evaluation team to increase the Commission's capacity to evaluate the impact of California's community mental health system, use evaluation results for quality improvements, and implement a data warehouse for the collection and tracking of mental health data and information. The plan is to allocate $1.1 million from the current fiscal funds, and the remaining balance will come from future years. Next is the Universal Mental Health Screening Study. Ms. Patterson is the lead staff for our study on universal mental health screening of children and youth, and provided the Commission with an update on the project in February. This project is still underway, and Ms. Patterson will continue to update the Commission on the progress made on this project. Next is evaluation of FSP outcomes. The Commission receives $400,000 ongoing funds to support the evaluation of full-service partnership programs. This year, the Commission is planning to allocate $250,000 to third sector to engage with counties, full-service partnership providers, state entities, and other subject matter experts to develop a best practice toolkit for FSP programs across California. And also, the next item is EPI. In January, the Commission approved $1.6 million for a contract with McKinsey to increase a strategic plan for early psychosis project, and this work is underway. As I mentioned, we are allocating a small amount of funds this year for early psychosis to help us communicate our learnings from this project. And also with our CYBHI, our Children and Youth Behavioral Initiative, the Commission received and scored over 200 applications for the CYBHI grant program. And I'd like to give a shout out to Tom Orrick and Ryan Kopchuk, sorry for mispronouncing your name, for all of the hard work that their team and their staff did on this project. It was quite a lot for this team to score 200 applications along with the other procurements that are already underway, and just wanted to make sure that we give a shout out to our staff. The Commission will receive $15 million technical assistance and funds to administer these grants. We've allocated $5 million to Stanford to provide technical assistance to the ALCOVE programs, and $5 million to UC Davis to provide technical assistance to the early psychosis programs. We have approximately $5 million remaining in this fund, and we will be coming back to the commission with a plan on how to allocate those funds best to administer this program. The next on the list is the Mental Health Wellness Act. The commission receives $20 million ongoing funds for the Mental Health Wellness Act program. We have allocated funds for empath, older adults, SUD, and we are in the process of allocating funds for 0 to 5 and maternal mental health. The commission will be presented with an outline for 0 to 5 and maternal health in May. We will also allocate funds for peer respite, and the commission will be presented with a plan for these funds later this year. And then the Mental Health Student Services Act, the commission receives $7.6 million funds to allocate for school county partnerships. And we're hoping to release that RFA that the commission has already approved the outline for that, and we're hoping to release that RFA in the next few weeks for that program. We also have $6.7 million for community advocacy, and we've allocated the majority of those funds. We still have about $970,000 that we need to allocate for K through 12 schools, which will also include a statewide funding for a statewide organization to conduct convenings and conferences for students. And the RFQ for that process will go out in the next few days, but we're shifting about $300,000 from our operating budget to support these conferences. And so that is all the adjustments to the commission's budget that I have to present. And again, just to also give you a little overview of what we're asking today for our spending authority. We're planning to allocate funding for breaking barriers, about $600,000 over 3 years, so $400,000 from this current fiscal year and $200,000 from future year to continue to support the Breaking Barriers Symposium. And as I mentioned, the K through 12 student advocacy, $970,000 for that project. Also, our mental health in the workplace policy project, there was recommendations in that report to create a centers of excellence. And we are working with UC Berkeley to hold a convening around these centers, and would like to allocate $150,000 to support these convenings. And as I mentioned earlier, the ongoing partnership with UC San Francisco for our research and evaluation, and then our full service partnership evaluation, $250,000 for third sector, and then $150,000 for Healthy Brains. And that is all the updates I have for the budget today, and happy to answer any questions you might have.
Thank you, Norma. At this time, I'd like to invite commissioners to offer any comments or ask any questions.
I have a question.
Yes, please, Vice Chair Alvarez.
Great, thank you so much. Thank you, Norma, for the presentation. Can you just share a bit about the commission's role in working with the organizations that are receiving the spending authority, particularly given that many of the priorities that these contracts are advancing align with the commission's work, whether it be school health, youth mental health? Where is the opportunity to weigh in on the use of those funds and either continued engagement of the commission or opportunities to inform the outcomes of the spending of those dollars? Can you talk a little bit about the relationship?
Later today, we'll hear on our strategic plan how we're planning to share information about all of the commission's initiatives and really looking at outcome-based management of our projects and our initiatives. And so we plan to, part of our appendices section of our strategic plan is to bring this back to the commission, really share with you our learnings and the outcomes, and really discuss the challenges too, what's working and what's not working. and engage along with our community partners and share with our community partners these learnings so that we have the community's feedback on the projects that we have underway.
Vice Chair Alvarez, I think I have a similar question to that, and I'd like to hear more. Thank you, Norma. Toby, if you could also, there's a couple of these partnerships that we've been involved in for a while, and I think I have the question where we continue to fund some of the similar ones, and I think the question is, and great that we have the funding, but what are the outcomes and how can we help inform the projects and not just cut the check, I guess, is I don't know if that's kind of in line with what you were asking, Vice Chair Alvarez, but right, how can we have a little more input into what's happening there? So, Toby, I would like to invite you to also answer. Thank you.
Thank you for the opportunity. So I think as you see in Norma's presentation, our budget is significant and it's complex and that it works across multiple fiscal years. In many of these areas, we're very hands-on, and we both work to, as staff, participate in the conversations around goals and strategy, or we bring in and support outside subject matter experts to support. So the comments about the Early Psychosis Project, for example, where we provide funds to counties to stand up evidence-based practices, and we fund experts from University of California, Davis to help ensure that there's fidelity to the model. And we participate in sometimes weekly meetings with the teams that are doing that work. That's true in the early psychosis work. It's true on our ALCOVE work. It's true in a range of areas. There are other places where we are not hands-on, and sometimes that is intentional, so that we are not overly influencing how these funds are used. And that is often in the funds that we provide for community advocacy, where we do a competitive process. There is an organization that wins a grant. We provide those funds. And although we monitor their use of the funds against the plan that they put in place, we don't put our thumb on the scale of how they use the funds unless it's related to distinctions between what they proposed and what they're actually doing, because we defer to the community to have a stronger sense of what would be impactful. And then there are some that are sort of in the middle, but also we have very significant staff capacity limits that make it difficult for us to attend all of the meetings that are happening as we not just monitor our own work, but we monitor the work that the administration is doing, say the 988 advisory committee that Commissioner Chambers is on, as our staff attend with her to support her as a representative on that body. So, Madam Vice Chair, I think would welcome direction of where you would like us to lean in more in areas. We are best at that when we have some expertise. It is challenging for us when we don't have that expertise. And so I would just ask you keep that in mind, because if the goal is to lean in an area where we don't have expertise, our standard strategy typically is to find people who have that expertise that we can support to provide that guidance, and then we have more of a monitoring role rather than a guiding role itself. Does that help? Does that answer the question?
Vice Chair Alvarez?
A little bit. I want to say, like, I'm encouraged for the opportunity to weigh in more, and also want to recognize the opportunity to put this incredible work in the hands of trusted partners that have gone through a process. And maybe it's a little bit of understanding what that process is to get to the distribution of these funds and why certain organizations are selected versus others, how to ensure that that work aligns with what the commission is doing, things to that effect. But thank you, Toby. I appreciate that. And we can start to think about that as we think about opportunities for input from commissioners as well as our committee members. So thank you.
Chair, I have a follow-up question along those lines as well.
Please, Commissioner Rowlett.
And so, Toby, given your explanation, and thank you for the presentation, I'm looking at the full service partnership evaluation, and while it's a smaller amount of money, two things just come to mind. I just want to make sure my understanding is clear. As a commissioner, I have a responsibility as sort of an ambassador for the public to ask questions as it relates to all areas of the commission's budget, but especially areas where I have some experience like this, full service partnership, and have been involved in that. And so I don't want to assume, but clearly you described what was a process, and I assume the process might be applicable here, where you went through a procurement process because you didn't either have the resources or the expertise within the commission to identify two organizations who would put together this evaluation, and you allocated, based on the commission's approval, resources or funds to get that work done. Is that understanding correct?
Let me explain the history of those. So on the third sector and the Healthy Brains in particular.
Please.
Yeah. And then I think, then it may not answer your question. It's hard for me to, there's not a yes or no answer to that one. So, quite often the commission is in a position to facilitate quality improvement in a space in this field, whether it's crisis response or jail diversion, whatever it happens to be. We probably have 30 initiatives, or have had 30 initiatives over the last 5 years related to that. In this particular case with third sector, the Ballmer Group funded third sector to support process improvements in FSPs in Los Angeles County. And in response to that, other counties were interested in joining that effort. And so the commission provided funds to expand the work that third sector was already doing, as they were selected by the client, in this case, Los Angeles County and other counties. So our relationship with third sector really started because county behavioral health departments selected them as a partner in coordination with philanthropy. So this is an extension of third sector's work based on the relationships that they've developed with the client, again, the county, right? Healthy Brains was similar in that a number of counties have been working with them with funding from us, and they have asked for some ongoing support to extend that work, namely work that is focused on outcome-based contracting. So we funded Healthy Brains to look at how counties are structuring their contracts with FSP providers. And they've recognized that the incentives in those contracts often is to bill Medi-Cal rather than to deliver a client-driven, tailored strategy to care. As you know, your experience may be more relevant here than mine. So a number of counties have come to us and said that in order to move their contracting strategies and their relationships with their providers sort of towards a more outcome-driven contracting approach, they've asked for ongoing support to sort of keep that momentum moving forward. So in some instances where we start from scratch, absolutely, it is a competitive procurement. It's very clear through a request for proposals. In others, it's a sort of a lighter touch. It might be a request for interest or qualifications, and then depending on kind of what we're trying to get done, how much interest is out there, staff tries to make very informed decisions about which mechanism is most appropriate. Even sole source contracting, in instances where that seems to be most appropriate given the amount of money, the time, and the initiative. So I would say yes, sort of, sir, as the answer to your question.
Well, the information in detail is appreciated, and I didn't have that comprehensive an understanding of this. Now I do, so I'm glad I asked the question. Thank you.
Can I ask a question, just for clarity from Norma? And I was sorry if I wasn't paying attention. Can you tell me what was the amount for the peer respites? Or was there an amount? You mentioned something about the commission. I might have missed it. I'm so sorry.
So the commission receives $20 million a year under our Mental Health Wellness Act funds. And as you recall, we've worked over the years to expand flexibility in how those dollars are used. Originally, it was only available for crisis response and only available in partnership with county behavioral health departments. And so statutorily, the legislature responded and opened it up and allows those dollars to be as much more flexibly for crisis prevention, intervention, and response, and to work with a diverse group of partners, counties, and others. Some time ago, we asked the commission to prioritize areas for investment. And so that is one of the areas that Commissioner Tamplin, when she was here, put on the list and asked us to put a proposal together. And so it's really up to the commission to decide. The investments we've made in the past have been between $10 million and $20 million.
This was really helpful, and yes, I just want to commend Commissioner Tamplin for uplifting peer respites. Usually like the wait, like in my county, is like 6 months or something. It's wild, the need for peer respites and other least restrictive crisis settings is important. So I look forward to uplifting and leading with staff in a fair, competitive process. And California is expensive, so we'll have to get creative and with property. Thank you.
Thank you, Commissioner Chambers. Are there any other questions or comments for Norma?
One other question.
Yes, please, Commissioner Robinson.
Just maybe, Norma, look into your crystal ball and see what you can tell us about expected budget impacts to us, given the state's budget deficit. I saw you referenced an early action. What would subsequent actions might they look like, and would that impact us at all?
At this time, we're not impacted at all. Our budget hasn't changed. Our proposed budget in the January budget is the same. We don't have, and we have some ongoing funds, so the budget looks, different, but we still have ongoing funds that are spent over multiple years. To my knowledge, at this point, there's no plan to reduce the commission's budget and future spendings. We'll learn more. Our budget hearings start in May, and we're starting to have those pre-meetings, and our budget hearings are starting, and so we'll learn more. But we won't know much more until the May revise is issued, and so that's the 10th of May. And so after the 10th of May, I can provide the commission with an additional update on our budgets and let you know what we find. But at this point, I don't know more than what I've presented today. Mm-hmm.
And Commissioner, I would add to that the way our budget is structured, because it has ongoing funds, and we typically allocate funds. We encumber the funds in a fiscal year, but they're available beyond that fiscal year. That actually gives us some flexibility to absorb cuts in ways that won't impact the dollars that we provide, because it allows us to say, if we're taking, let's say, the $20 million of the Mental Health Student Services Act, Mental Health Wellness Act, we typically bundle that across multiple fiscal years. So if we do not release dollars at the end of this fiscal year, for example, we can use next year's money instead, or not next year's money, but the following year. And so that multi-year planning gives us a cushion that we can, now if the cuts are too deep, that cushion will not be sufficient. But as Norma says, we'll need to know more in May, but we are confident that there's enough flexibility in the timing of the dollars and how we spend these dollars that any cuts should not impact our internal operations and also should not impact our local assistance efforts. That may change. $70 billion budget deficit, all bets are, risky, but that flexibility is built into the design.
Thank you, Commissioner Robinson. Any other questions or comments on this agenda item? Okay, I see none. So at this time, members of the public may request to make public comment on agenda item 9 by clicking the raise hand button on your computer or the app, or if calling in by pushing *9. Are there any public comments? Mariani, please raise your hand now as the queue will be closing.
We currently have one public comment from Stacy. Stacy, your line's open. You can go ahead.
Good morning, Commissioners. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I wish I could be there at the meeting, but wasn't able to go to Sacramento. Anyway, I really want to commend Chair Madrigal-Weiss and Vice Chair Alvarez for asking good questions, and other commissioners, because these projects, I feel I would love for the commission to have a little bit more involvement, or at least their eye on it. I would also like that if the commission staff could make sure that when executing contracts, that reducing disparities and the ability to serve BIPOC and LGBTQ+ communities are always brought to the forefront. I'm hoping for a little more research or interaction besides just having a DEI inclusion, diversity, equity, and inclusion statement on their website, but ensuring that the staff and board have people from diverse communities representing all the people of this state, and that specific staff from these organizations working on projects with the commission are representative of the diverse communities of this state. REMCO believes that the commission has a large enough staff and budget to consider having an expert on staff in matters of DEI to review processes, contracts, etc. As while we believe all the commission staff may be committed to serving BIPOC and LGBTQ communities, not all may be skilled in understanding how to evaluate and monitor whether an organization is able to serve these communities. I realize this last recommendation may be a little beyond this agenda item, but we wanted to plant the seed for how the commission could improve its efforts to reduce disparities. Thank you.
Thank you, Stacy.
And that was our final public comment.
Thank you. And none in the room, Mariani?
No, there were none in the room.
All right. Toby, I'm going to ask that you explore the options with our budget partners. Those comments that Stacy made, I think it's extremely important that we work with partners who, support not only our strategic plans, but also mission, vision, and principles. And I think we need to, be more action-oriented around this and not just to the words and to that which is highlighted in our website. And I want to see the same things. So if we could, please. Thank you, Toby. Okay, we are going to now, I'm going to ask for a motion and a second regarding agenda item number 9, please, do we have the motion? There we go, that the commission approves the revised fiscal year 2023-2024 spending plan.
So moved.
Thank you, Commissioner Carnevale. And do I have a second?
Second.
I have a double second. That is Commissioner Bunch and Danovich. Thank you. So Maureen, we have a motion to approve in a second. Could you please take roll?
Yes. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Shen.
Aye.
Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette. Commissioner Rolette.
Aye.
Vice Chair Alvarez.
Aye.
Chair Madrigal-Weiss.
Aye.
The motion passes.
Thank you, Maureen. All right, we are back on schedule. However, just to transition, we are going to take a 5-minute stretch break. So see you back here in 5 minutes. Thank you. Okay, we're going to go ahead and get started. If I can invite commissioners back. Clap once if you can hear me. Clap twice if you can hear me. Clap 3 times if you can hear me. Commissioner Brown. What else can I do? Commissioner Brown, Commissioner Carnevale. All right. Welcome back, everyone. Agenda item 6, we will be focusing on the passing of Proposition 1 and the transformational change in behavioral health. The Commission has invited leadership from the California Health and Human Services Agency to outline their strategy to implement Proposition 1. Our goals for this presentation are to understand the state's plans to implement Prop 1, identify the role of the Commission, and provide the public with an opportunity to hear from the administration on its plans. I would like to welcome Stephanie Welch, Deputy Secretary of Behavioral Health at the California Health and Human Services Agency, who will be presenting on this topic. Stephanie, thank you so much for being here. We welcome you, and the floor is yours.
Great. Thanks for having me back. Happy spring. I am allergy challenged today, but hopefully I don't lose my voice because we have a lot to talk about, and I know this is a pretty significant agenda item. First and foremost, coming from the administration, I think I want to there's a couple of things we're going to talk about today. One is, I think that we really see this as an exciting, I don't want to say a reset because we've been in the middle of transformation for 3-4 years now, but it's really a culmination of many of those early initiatives. So we're going to talk a little bit about them because I'm hoping that in the next couple of months, people are starting to really see the pieces of the puzzles coming together in not a patchwork way, but in I guess I'd like to say a mosaic way of working together. Could you remind me how much time I have? Okay, well, great, because I can be really long-winded. You think that's a long time, but not on this topic. Let me make sure this works. This way? No. I'm pressing the button, but nothing's happening. Maybe I need to do this.
Hold on.
Sorry, guys. Well, I think while we're trying to fix that, I hope this is the beginning of a lot of conversations. I have a feeling that maybe I need to get a nameplate and just keep this because I'll probably be coming to visit and giving you guys updates on a regular basis. But can share that I guess it's gone. Where did it go?
They're working on it.
Oh, okay.
It might be a battery issue, so.
Oh, okay. We can also have someone advance the slides. Great. But wanted to share that even on a staff level, thank you, we've started to have more meetings and we'll look and have to have many internal meetings on a lot of the stuff of what we've been working on since the official passage of the proposition has been on kind of coordination, internal governance, and communication structures. Because we have multiple departments and entities that are involved. So we've been doing a lot of internal work in that way and have appreciated the involvement of your leadership in some of those discussions. So let's jump into the presentation. Before I go into the details of Prop 1 and talk about where I think there are some really exciting opportunities, did want to really underscore, and this is, I think, something that is important for all of us to practice right now, is like taking a deep breath and exhaling and realizing that technically the first 3-year plan is not implemented until July 1st, 2026. It does not mean that we don't have a significant amount of work to do in the next 24 months. We do, but I want to be clear that there's a lot of planning and discussion that needs to take place prior to then, and we look forward to engaging with folks in that process. So that being said, it's very important to the administration to also lift up that we are still in the midst of a behavioral health crisis, and our county partners and implementation partners, all of their contractors, CBOs, and networks of care are busy already implementing a couple of pretty major changes. And so we're going to at least touch on those today, because I still think that it is absolutely of the utmost importance to this administration to focus on really what are the more targeted populations in the revisions to the Mental Health Services Act, which are people who are experiencing really significant behavioral health challenges. So that's why we have a quick section that we're going to go through on things that we can do to act now. We'll go over the bond in a lot of detail, actually, as well as the BHSA. I want to lift up opportunities where I think there are exciting changes, and much of those of interest to this particular body would be around the early intervention and prevention pieces. I am going to spend some time, because I think it's one of the really exciting things about the BHSA is the section around enhanced accountability. You are still the Accountability and Oversight Commission, so I think it's an area to spend some time on, and my intent is to have a lot of time for question and discussion. So first and foremost, these are the priorities and the commitments that this administration has made to Californians. Our intent is to increase the availability and accessibility of mental health care and substance use treatment, regardless of payer. We do really believe that we are leading the nation, certainly in investments around behavioral health services, including facilities, housing, and workforce. Those essential infrastructure pieces are critical to being able to expand those services. We have a newly sharpened focus on accountability for results in this space around behavioral health care. That's not just the carved out specialty county administered behavioral health system, but that is also our Medi-Cal managed care plans that serve the mild to moderate, and also our commercial plans who serve people who have employer-based insurance. This is really important to do in partnership. I think one of the exciting things that you guys have been kind of trailblazing on is some of those partnerships with our kind of public and private entities, people outside of government, so to speak, who are helping with some of your innovation projects and helping you think innovatively. That's really important if we're going to close the gap between what we know works and what we actually practice. And then we'll talk about the importance of taking action now. While we'll be really busy doing a lot of planning, there's obviously work to do every day to shore up gaps in care. So I want to go over just real quickly things that have been put out in the ethers and are available now for people in particular to focus on the high risk, high vulnerable, more acute populations who are experiencing behavioral health crisis. So we'll talk real quickly about behavioral health bridge housing, mobile crisis, AB 988, full service partnerships being a tremendous vehicle to serve this high need population. We'll talk a little bit about the CARE Act, which goes into full implementation by the end of this calendar year. LPS conservatorship reform is here. And there's a lot we've been doing in our opioid response. So behavioral health bridge housing, I don't know if we've ever talked about this here, but we have about upwards of close to $1 billion that has gone out to counties, and they are doing incredibly innovative things with these resources. So you'll see here that with those resources, of which the majority is for things like rental assistance, interim housing, and what we would refer to as patches for board and cares. Counties can use up to 25% for brick and mortar infrastructure. This is really intended to quote unquote be bridge housing. Think of this as kind of the training grounds for the 30% requirement for housing. It's pretty similar program and is really intended to be the bridge until when counties will start utilizing their BHSA dollars for housing intervention funds. But I also just wanted to point out that counties are acting very quickly to utilize these resources. And I wanted to share with you an example from Fresno County, where the Department of Health Care Services, who's administering this program, provided $21 million to the county for this particular project. In January, they started housing 60 people. They have another location that's opening soon that will house another 120 people. And so really excited that counties are working very diligently and fast to come up with these types of housing opportunities for people now, and not necessarily having to wait until the changes are in place for the BHSA. Okay. Also wanted to lift up, I know this is of interest to this group, that we're really making a lot of progress with expanding our Medi-Cal mobile crisis services. Right there, what you see, if you don't recall, is actually the first round of our behavioral health infrastructure program, which from now on I will refer to as BCHIP, was to invest in the infrastructure needed to support the expansion of crisis teams. And so the counties have worked diligently. This is a challenging thing to do, but we have 304 new mobile crisis teams in this state who now, as of January 1st, for many counties, 31 of them, can receive Medi-Cal reimbursement for mobile crises. We are looking forward to the goal of all 58 counties having this capacity by midsummer. Also wanted to lift up, while we want to have appropriate crisis response, the goal is to try to prevent crisis in the first place. We'll talk about that in a lot more detail later this morning. But we have been making a lot of progress supporting the capacity building of our 988 crisis centers. They're the ones who take the calls and try to work to de-escalate or help navigate or support individuals who are in behavioral health crisis. Our call volume has increased almost 20% in the last year, and we still have maintained a 90% in-state answer rate. We met with our 988 Policy Advisory Committee yesterday and really are excited that by the end of this year, we will be submitting to the legislature a 5-year implementation plan to kind of achieve the whole vision of AB 988, our state's law around 988, which includes strategies to prevent crisis, strategies to respond to crisis, and strategies to stabilize and support ongoing recovery and supports from crisis. You guys, I don't have to tell this body at all, but for our public partners listening in, full service partnerships are a tremendous resource and strategy to serve those who have some of the highest needs. You know, it is our do whatever it takes model. This also is a model that now counties have often used to actually pay or provide housing supports, rental subsidies, things of that nature for people in full service partnerships. And as we transition to BHSA, this would be a really important part locally for those who are interested in engaging in the local process, to make sure or to ensure that these full service partnerships are operating and serving these populations with high needs. For right now, full service partnerships are focused on people with serious mental illness and children and youth who may have serious emotional disturbance. That will expand to be inclusive of people with substance use disorders as part of BHSA. CARE is underway. We have 8 counties who represent the majority of the state's population who are working diligently to implement CARE. Just wanted to share that if you didn't know this and you're in a county that's has not implemented yet, there are planning dollars out there. I'm sure that counties in the cohort 2 kind of contingency have already been working really diligently on some of this planning. I would encourage you guys, whether you're a peer or a family member or a public safety partner or a housing provider or someone who maybe works as a public guardian, to get involved in that planning process. From the early start, we have really learned from our cohort 1 counties, which we spent a lot of time with, that one of the keys to success has been early and often collaboration between our court partners, our housing and social services providers, and of course, at the center of that, the behavioral health providers. So just wanted to take a minute to share just a couple of photos from our recent site visits that we've done. I think one of the things that has been really promising, and we're doing a survey right now to try to kind of quantify some of these outcomes, but what we're learning from our cohort 1 counties is that this intensive engagement and also the ability to do a true to fidelity ACT model FSP with this population has really been effective, and most notably really effective at engaging someone early. If you don't recall, CARE has 2 different kind of off-ramps from a court-ordered care plan. This has been, counties have been very successful in many cases in being able to work with someone and get them into voluntary services or re-engage them. Oftentimes these might have been somebody who was in an FSP, but they, I don't want to say got lost, but they maybe for whatever reason dropped out of services or stopped participating, and this has allowed them to re-engage with clients that they were previously serving. I wanted to lift up 2 of those pictures because one, you'll see there's a big van, and that mobile van is not only where mobile outreach takes place, but it's also where court is held. A lot of the work is actually in the community, mobily holding court, but also doing intensive outreach and engagement. It's been a lot of peers and homeless outreach and engagement workers who have been doing the initial engagement with potential care participants, and that has been really, really effective. Also wanted to lift up in terms of talking about behavioral health bridge housing and what counties are doing super creatively fast. Up in that top corner, Little Tuolumne, I'm giving a huge shout out because it's a small county, and they were able to use their behavioral health bridge dollars and some other different dollars, including opioid settlement funds, to purchase an abandoned or a vacant, more like it, skilled nursing facility, rehab it into interim housing. There are several, I think there's over 20 units, and they have a bathroom, a little kitchenette, and really we're able to do that in a very short period of time. And it was actually the community that came in, various different local charities that donated all of the furniture, painted the building. We went and visited with a couple of their board of supervisors who championed the project in the face of NIMBYism, because it happens to sit in a lovely community with beautiful views of it was outside of Sonora, so I'm not familiar with what the name of some of those mountain ranges are, but really amazing that it was actually their local board of supervisors who really championed making sure that that program or that particular site was successful in getting cited, and now people are utilizing it. So I'm going to keep going on here. Just wanted to lift up that our Department of Healthcare Services has issued a guidance notice around LPS reform as passed under SB 43. That hyperlink is there for your review. It clarifies allowable sites where people on the expanded definition of grave disability can be taken. We were given some feedback that more clarity would be helpful in people's planning, so we are in the midst of developing a frequently asked question document. And also just wanted to lift up, there are 2 counties that have already implemented this new piece of legislation, sharing that there. And then lastly, this is really too much to look at, but I think it's an important piece to end on because we're going to transition into talking about Prop 1 now. But again, and I know you guys have heard me say this before, the fact that we were able to expand the Mental Health Services Act into the Behavioral Health Services Act and be inclusive of basically our fellow peers who are living with substance use disorders, we get to really leverage and hopefully build on many of the investments that we've been making to address the opioid crisis. I think most notably the things that we've been focusing on through our resources that we've had to tackle this problem is really reducing barriers to care, making sure that people have access to treatment, including our medication-assisted treatment expansion program, and increasing our ability to support service providers. Okay, so that just really summarizes some of the things that are out there now. to be knowledgeable of as we continue to plan around some of these changes. I think some of these things that I've talked about are really great areas to learn and train to be prepared for BHSA, whether it be how do you do behavioral health bridge housing, how do you really start thinking about a full service partnership program that has levels of care from ACT fidelity model down to lower levels of care. And how do you use some of the other tools, like the things that we've been doing in the SUD space to build out your SUD continuum. So, building for transformation. As a quick refresher, the other portion, the non-BHSA portion of the bond was AB 531. That provided us with $6.3 billion of bond funding. 4.4 billion of it will be for competitive grants for counties, cities, tribal entities, nonprofit and private sector partners to build out behavioral health treatment settings, including and emphasizing residential settings. Of that 4.4 billion that is available, 1.5 billion with a 30 million set aside for tribes will be awarded competitive grants only to counties and cities, of course, and the tribal set aside of 30 million. These are competitive grants, and they will be modeled on the behavioral health infrastructure program, and we're going to go through a couple of those rounds in just a moment. Additional requirements may be necessary, and this is just due to the provisions of receiving actual bond funding, and that's different funding than what we had for BCHIP. And we will outline that in our request for application. So super exciting because, BCHIP was a $2.2 billion program. I don't know if I've said this here, but I've certainly said it in budget hearings. We have in our 5 rounds of BCHIP, technically really 3 rounds because those are the rounds that were actually brick and mortar buildings at least, close to $12 billion in request. So still going to be very competitive for this $4.4 billion. But it was really, it's been really exciting to see how much commitment and interest and willingness people have to build more behavioral health treatment options and service options in the community. So I'm going to go through this quickly. It's a lot of content on the slides, I recognize. But I know you guys want to have lots of time to talk about other elements of the BHSA. But we already talked about round 1, which were the crisis care mobile units, and so I'm not going to go into detail with that. BCHIP round 2, and this is kind of, I think, important for the community and for our county partners out there. We did award 39 planning grants, and really the intent of this round was to give counties an opportunity to assess what their needs were. What did they need in their community? Did they need a sobering center? Did they need SUD residential treatment? Did they need all of the above? And so those may be actually good things to kind of dust off. I'm sure they're actually being actively used by the counties, but to see if that also is going to be helpful in terms of thinking through what counties should be thinking about applying for under the bond portion of Prop 1. Round 3 is our launch ready section, so over $518 million for eligible counties, same thing. These were things that were shovel ready. We do have things that are open already. I'll go over that in just a second. I know my colleagues at DHCS are going to a grand opening tomorrow, which is exciting. Round 4 was the round that we focused on children and youth as an accompaniment to the Children and Youth Behavioral Health Initiative. So that's $480 million that went out. And you'll see there that it created 29 new inpatient and residential facilities, as well as 67 outpatient facilities for those who are 25 and younger. Round 5 focused on crisis and behavioral health, $430 million. Again, new residential facilities and new outpatient facilities. And I'm going to summarize some of them here. So now, granted, things are not necessarily all built yet. It takes a while to build a building. And that's one of the reasons why bridge housing is so helpful in the interim for those who need things like patches for board and cares, et cetera. But here you'll see in our first 3 rounds, and think of, We're going to have 4.4 billion additional dollars. This, what I'm talking to you about right now, represents 2.2 billion. So hopefully we're really going to be able to exponentially achieve what we've been able to achieve with BCHIP so far. So 2,600 total inpatient and residential beds. That's a very long laundry list of all the different beds. I really want to point out the one that has the big numbers because this was a huge unmet need statewide in our behavioral health needs assessment, and that's the over 1,100 beds plus for adult residential SUD treatment. Next page represents all of the outpatient slots that we have created with this funding. So over 280,000 individuals are estimated to be served in the expansion of these slots. And so you see a lot of numbers there. I know this is a group of, an organization that has really championed crisis, and you'll see right there over 66,000 crisis center stabilization unit beds. You've got over 80,000 projected people who will be served by community wellness and prevention centers. So really exciting things that are coming down the pipeline, and looking forward to having more opportunities to build more things with our bond. So this was the very first BCHIP building that opened. It opened, I think, a couple months ago. It was in Nevada County, so shout out for Nevada County. It's located in Truckee, and with just $2.3 million, it's going to be able to serve 600 individuals for hospital-based outpatient treatment care for both psychiatric services and also medicated assisted treatment for people who are living with substance use disorders. Okay, so quick transition into the supportive housing section of the bond that will be administered by our colleagues at the Housing and Community Development Department. This diagram identifies the nearly $2 billion that goes to HCD. And you'll see that about pretty evenly half of it is going to go to, I'll talk about in a section, something that's modeled after our successful Home Key program. And the other half is going to be dedicated to serving veterans. So first, the supportive housing, modeled after HCD's Home Key. And again, the thing that'll be different about it is that it has to be targeting people who are not just at risk of homelessness, but have behavioral health challenges. And this will be for acquisition, rehabilitation of hotels, motels, hostels, and other assets that can be converted into permanent housing. And the entities that are eligible to apply for these funds are cities, counties, regional and public entities. So wanted to show you a couple of examples of what these look like. This is probably the most traditional when people think about Home Key. I don't know if this audience is familiar with Home Key. I'm going to think that you probably are at least slightly familiar with Home Key. Home Key is a program that came out of the response to COVID. It started as Project Room Key, where we quickly tried to get people who were living unsheltered into hotels and motels. And then we realized that we could purchase these and turn them into permanent supportive housing. And so here's a great example. This is in the city of Healdsburg, 22 studios, on and off-site support services, and it's located within 1 mile of a grocery store, close to transit, et cetera. Here's an example I thought you guys would enjoy. This is in El Centro in Imperial County. It's a partnership with their local community college. These are 25 permanent units of manufactured housing, and they're dedicated to transition age youth, with priority going to youth who are graduating from the foster care system. I actually have a whole deck with all sorts of examples, but we want to focus on some of the BHSA changes. I will share that deck with Toby, so that if you guys are interested in some more of the examples of what has been built with our Home Key program, we can certainly share those. So the over $1 billion worth of housing investments are earmarked for veterans who are experiencing homelessness, at risk of it, or and having a mental health or substance use disorder. So CalVet and HCD will coordinate to determine the methodology of how these funds are distributed. And they're working on a component of it is really to make sure that whoever is administering the supportive housing, that they have a coordinated service plan. I have learned a lot about the veteran system in the last 6 to 8 months, working with CalVet on a couple of different projects. And it's really been interesting how many changes are happening. I think one of the myths I wanted to share with folks is, you know, a lot of times people think that just because somebody is a veteran, that they have, you know, ample access and a full array of services that are provided through the Veterans Administration, and that's not necessarily the case. So the purpose of these plans is really to strategize and leverage what kinds of services are available through our Veterans Administration and what kinds of services are still needed. So this particular set of funds, similar to our BCHIP, everything is really building off of existing programs. And that's partially because when you see the timeline for this, you'll see how fast we're going to move. It's actually really helpful because we already have built internally the skill set to do this work. And I can speak for our department, who has really gained a lot of expertise in the last several years administering the BCHIP program. And that was intentional. The legislature really wanted us to leverage programs that had already shown success. And so this is a program that was approved by also a voter initiative in 2024, and it provided $600 million for affordable housing for veterans. What we're really doing is just adding money to that program and making sure that it's going towards veterans who have behavioral health conditions. Okay, I know that's a lot. So everyone take a deep breath. We're past the bond. We will focus on the BHSA. And so it says plan and act because I think, like I mentioned before, we're going to be doing a lot of planning together. You'll see what I mean when we go through these slides. But that doesn't mean that we can't start acting now to be ready for these changes to be in place. So I wanted to put this up to ground us once again in why we embarked on these changes and wanted to modernize the Behavioral Health Services Act. One was, of course, we have a lot of Californians who are living with serious substance use disorder. But probably more important, that's not reflected in this slide, is that the landscape of how we fund our mental health system has dramatically changed in the last 20 years. Whether that be the ACA and just Medicaid expansion, or the fact that our Medicaid program, Medi-Cal here in California, has caught up with the needs of the people that it serves, being able to provide more services that really meet the needs of people who are in need of them. One of those examples, being something like an ACT model for people who have very serious behavioral health challenges. And also happily now having things like peer services as part of our Medicaid program. And I mention that because the other major thing that happened was that we have been making huge strides in achieving more parity between commercial plans and our Medicaid program. And I was telling my colleague, Allie, I was in a meeting before coming here and talking about one of the other commitments that we made as part of behavioral health transformation, and that was to assess where there were gaps between commercial coverage and Medi-Cal. One of those gaps, because I know it's an interest to this group, is things like peer services. So we remain committed to looking at how do we support people who are receiving commercial insurance to get the kind of care that they may need, and doing that in a responsible way. So that's also part of this. I've said now a couple of different times in different settings that part of what I think is so exciting about these changes is how do we get the three systems who really serve people with behavioral health conditions to operate at their peak level. So how do we get our commercial plans to see that doing more coordinated care for populations who maybe are experiencing their first behavioral health crisis could really prevent further crises and keep them employed and then keep them on their insurance or keep them with their insurance coverage. How can we support our Medi-Cal managed care plans to do more to intervene and act early so that people on Medicaid who are experiencing a mild to moderate behavioral health condition can get some resources so that they don't spiral into needing the high-level specialty care services of the county-operated specialty mental health system. Okay, thank you for indulging me in sharing that. So I really don't need to tell this audience about some of the goals and kind of summarize some of the changes of the BHSA. We'll go through real quickly. So there's an updating of allocations for local services and different state-directed funding categories. I would really recategorize that as new state responsibilities with directed funding. It broadens the target population to include people with substance use disorder, just an incredible opportunity. Focuses on the most vulnerable and at risk, and this is including children and youth. It clearly advances community-defined practices as a key strategy of reducing health disparities, and it increases community representation in a variety of different spaces. It revises county planning processes and improves transparency and accountability, something I know people have been very interested in seeking. So a lot of words on this particular summary slide. We're going to go through each of them slowly. So BHSA allocations, you'll see there, full service partnerships is 35%, housing interventions 30%, behavioral health services and supports 35%. This is kind of the bucket that includes outreach and engagement, but 51% of those dollars must be dedicated towards early intervention, and of that 51%, those early intervention services should be dedicated on individuals who are 25 and younger. There are new state responsibility funding categories. The state moves from 5% of the total funds to 10% of the total funds. The majority of that is this now 7% that's dedicated to new state responsibilities. That includes 4% for a population-based prevention component and 3% for a sustained statewide workforce investment. We take a haircut of 2%. I don't know if that was the budget conversation I was walking into, down to 3% for the state to administer ours and fulfill our obligations around the BHSA. And then just noted there, and we'll talk about it in a little bit more detail, there's $20 million that's dedicated for you to lead on helping us do innovation partnerships. So, wanted to lift up before we get into some of the details that these allocations are flexible, and wanted to make sure that people knew that 7% of any amount in any bucket can be moved from one category to another for a maximum of 14%. I think this is going to be a very important tool in the early transition. So if a county wants to move 7% out of their housing intervention bucket into their FSP bucket, or maybe they want to move it to their BSS, I still haven't gotten that one down, the BHSS bucket, they can do that. Or maybe they really want to double down on their investment in FSP, so they move 7 out of housing and 7 out of the early intervention into the FSP bucket. And this was really intended to be responsive to the differences that counties have. And we'll talk a little bit about a few other areas where there are potential exemptions based on meeting criteria that will be developed in partnership with counties through DHCS. Nothing changed in terms of the 3-year planning cycle, and counties can change this every 3 years. Maybe they've been super successful and they've opened up some new supportive housing units, and they want to reduce their investment in their housing piece by 1% or whatever. The idea is to be flexible. The other thing that's, I think, really important is that all of these buckets, and I'll talk about what the mechanism is for this shortly, but all of the buckets, counties can continue to do innovation in and are encouraged to do so. So this is a sample BHSA allocation. It's really hard to read, and I don't have good enough eyesight from here to see what the numbers are. But I think it's kind of helpful to take a look, probably of interest to this body. You know, when you think about that 3% and that 4%, we're looking at, I think, about $140 million annually as a floor, probably, for population-based prevention, and about the 3% comes to about I think about 120 for a sustained workforce investment. So, and again, I forgot, we haven't gotten to it yet, but there's also an earmark of 51% of the dollars have to go in the population-based prevention towards youth and children. And the reason why this is a sample budget is that, as you guys might be very aware, the last couple of years we've had a lot of fluctuation in the Mental Health Services Act fund. We had a year at one point, it was upwards of close to $5 billion, and now it's back to a more average, which was around 3. So one of the critical components of this, and I know you guys are going to be tremendous partners in this, is really having a lot of engagement with local government in order to make this happen. You know, they are the entities who are responsible for delivering the services. And so these are some areas of the statute that require a lot of partnership. So we'll be working with our county partners. I believe you're a part of that as well. I have a slide on that, to develop a county behavioral health outcomes accountability and transparency report. There also will be engagement with our county partners to establish a biannual list of evidence-based practices and community-defined evidence-based practices for our early intervention programs. We'll be working with our county partners and all of their expertise to develop levels of care in our full-service partnerships. I believe you guys are engaged with us, or we haven't started that, don't worry, in doing that as well. We will be soliciting county input on the various different criteria for exemption processes that I will walk you through. And there are other, I think the one thing to mention here is that I don't have a slide on it, but we do have a revenue stability work group responsibility to fulfill. You guys are a part of that. We have not started that, and that really is intended to look at strategies in which to smooth the bumps in the MHSA fund so that counties have ability to do more long-range budget planning because they're not having a $5 billion year bumped up with a $3 billion year. And so that work has not started. I think we're eager to get that work started soon. So community engagement changes pretty dramatically as well. Of course, this is now the BHSA, and we want to be very thoughtful and inclusive of our SUD partners. You guys probably experience the most change, but we certainly have more change at the local levels. Wanted to make sure that there are the membership's really modernized with the proposal. So we've got SUD perspectives that are included. And, you know, as they do now, those county behavioral health advisory boards, we want to support them to be really involved in fulfilling their role and responsibility. You'll see there in the integrated plan for behavioral health and outcomes, one thing that I think is important is that there are a lot of new reporting requirements. There's no doubt about that. And so we have, with the statute, supported additional resources. Think of like the 2% that was at the state to have the 5% for state administration. Well, we gave that 2% to the counties, knowing that this was going to be a lot of work to do the kind of reporting, the planning, the quality, the outcomes, the data reporting, the contractor and subcontractor oversight that they would be needing to do. So small counties can use up to 4%. All other counties can use up to another 2%, and this is on top of the 5% that they're allowed to use in this way. Also, really want to lift up. I'm not going to go through the detail of what is probably a dozen, if not more, entities that are now required to be a part of the planning process. Anything from local areas of aging to county education departments, things like that. 0 to 5 partners, et cetera. They're all now required to be part of the planning process. You guys can look at that detail on your own, but I did want to really lift up that there is language in there that says that it's important for counties to use some of those resources to support training and technical assistance to ensure that local stakeholders have enough information and data to participate, meaningfully in the development of 3-year integrated plans and annual updates. You guys are kind of familiar with your own changes, so I'm not going to go into a ton of detail, but boy, do you have some growth happening in bringing new perspectives and additional perspectives to your commission to reflect what's different 20 years later. Excited to have some youth participants, participants of individuals who have loved ones or have experienced a substance use disorder. Individuals or organizations, I think rather, that serve older adults, are well-versed in understanding community-defined practices, et cetera. So let's talk about timelines. This is very high level, but kind of grounds us in some major milestones of where we're focusing our efforts at our Department of Healthcare Services, who really is the engine that will be leading these efforts within our agency. So starting now, we'll be kind of kicking off our stakeholder engagement. We are still in design phase on some of these pieces. This is a lot that we need to think about, but first and foremost, we want to make sure that people know that we are committed to that. And also we will start by having monthly public listening sessions. We had the first one last Friday about the bond. There will be information here for all of the public stakeholders as well to make sure that they know where to find information about when those are happening. I think probably the biggest thing and the thing we feel really excited and eager and capable of putting out first is the guidance for our bond funding. We intend to put that out by the beginning of this summer. And so we know that it takes a while to build, and so we want to get started right away, and we have a program that we can leverage to do that quickly. And then we will be working very, very hard over the course of the next 6-8 months plus to develop the guidance for the integrated plan. Our goal is to put out that guidance by the beginning of the new calendar year, so January of 2025. I kind of start blinking when I say that out loud. But roll up your sleeves and get some rest. We've got a lot of work to do. And then, all of that is intended, we want our locals to have as much time as possible to do that kind of planning. And so, we want them to have the time. And so that's why we're going to press ourselves to go as quickly as we can so that they have the time to put those plans together. And then the first plan that represents the changes that we're going to talk about in detail would be the first 3-year plan in July 1, 2026. Okay, so that's all the, it's a lot of detail, but now I'm going to dive into even further detail about where I think there are the most exciting opportunities and curious to see where you guys are all excited as well. So first, we have aligned our priority populations that are served with BHSA dollars with our Medicaid program. This is really important because these are all populations for the most part who are eligible for Medicaid. And so it made just tremendous sense to be focusing on who are the priority populations in that program. So you guys can read those at your own. And then also we've got some really exciting elements in here to advance health equity. And I think this is an area where you guys have done and provided some leadership in. And so there's a lot of language in there that talks about wanting to really reduce silos. And we're going to talk a lot about the opportunities in particular in the early intervention component, but also to advance community-defined practices in the FSP category. There's some great information and requirements about stratifying data so that we actually are able to really look at the outcomes through stratified data so we can identify where we want to advance if we are issues around equity. And again, just a lot of additional representation of diverse perspectives in both state and local oversight bodies. So I think I've already kind of talked about this, but really excited about the opportunity to have more capacity to serve people who have primary substance use disorders. And one of the ways in which we're going to manage this is that counties must use data to appropriately allocate funding between mental health and substance use treatment services, as well as identify strategies to address disparities between the level of service that they're providing for mental health and SUD. This is clearly articulated in the section around the integrated plan requirements. So getting to behavioral health housing interventions. I'm going to actually walk through this in detail because I want to make sure we get to the details. So the target population for these housing interventions are children and families, youth, young adults, and older adults living with serious mental illness or serious emotional disturbance for our kiddos, which is not necessarily a term I love, but and or SUD who are experiencing or at risk of homelessness. So it's really important because I've heard this a lot. There's a lot of people who are definitely living in unstable housing. And so I think that this is important to know that we want people to feel stable in their housing. And so what this actually pays for, rental subsidies, operating subsidies, shared and family housing. We'll talk, there's some capital in there that is allowed. And then for when we have our BCHIP, our BH Connect waiver approved, then which has a component in there for 6 months of transitional rent. This can be used to cover the non-federal share of that transitional rent. So 50% of funds are prioritized for housing interventions for people who are chronically homeless. Obviously, they have behavioral health challenges or they wouldn't be served by this population. Up to 25% may be used for capital development. For our small counties, those are counties that have a population of 200,000 or less. They are exempt from this requirement in the first planning cycle. And actually, if you look at the statute, it says and ongoing if approved by DHCS. I think that's really important. And these housing interventions are not, you do not have to be in a full service partnership in order to be eligible for it. I think I've heard at least from some folks in county land that there's a lot of people who are unhoused, but they are stable in outpatient care. And so how do we support them to have stable housing? And I think that might really advance their recovery, I would think. And potentially maybe they can be stable in an outpatient program outside of the county operated system. So provides flexibility for the remaining counties commencing in 2032, 2035 planning cycle. And again, this is based on the DHCS criteria. I think we're obviously very hopeful that we'll be more successful with addressing our homeless and unsheltered crisis. I think we're hoping that we'll be very successful with BCHIP and other pieces of our other system that's investing in all of our housing service providers and entities that are investing in building more affordable housing. And so we wanted to make sure that we were putting some flexibilities into these requirements. Because we don't know necessarily what the world's going to look like 10 years from now. So moving on to full service partnerships. So full service partnerships, this includes mental health supportive service, substance use disorder treatment services. It includes the ability to support medicated assisted treatment and community defined evidence practices as part of that array of bucket of services. It lifts up that assertive community treatment and forensic assertive community treatment, I'm doing a lot of talking. Supported employment and high fidelity wraparound are required. There are small county exemptions for this. Sometimes in a small county, you just don't have the capacity to do some of these things, or you need more support and time to build capacity to do so. And so there are some exemptions in that space. These are also all things that are part of our BH package. So our BH Connect package, these are new services that we are seeking approval from CMS to receive FFP. So it would be part of the optional array of Medi-Cal services that counties can provide if they opt in to do so. As I mentioned before, we are establishing levels of care based on criteria. This is just to acknowledge that, I think the whole point of putting someone in care and giving them intensive wraparound services is that they're doing better and they might be able to step down from a high level of care, but people have things that happen and they need a high level of care again. So it's really intended to support flow in and out of systems. Outpatient behavioral health services are also supported in the full service partnership category. They can be clinic or field-based. If they are necessary for ongoing evaluation and stabilization of an enrolled individual. And I think that our data would show, and I'm sure that our county partners and clinical partners in particular, is that things happen in people's lives, and it's hard sometimes to keep someone enrolled in a program because things are happening in their lives. So this would be trying to support that field-based or clinic work in that way. And then also ongoing engagement services that are necessary to maintain enrollment of individual in their treatment plan, inclusive of clinical and non-clinical services, including services to support and maintain housing. So this is just really to recognize that for our really high needs, high risk, high vulnerable population, they may need ongoing engagement services in order to stay enrolled in their treatment plan. So really look forward to working with all of you. You are identified as one of our partners in working on developing those FSP levels of care. Okay, behavioral health services and supports. This is the last bucket per se. So this basically includes all the other parts of the original MHSA: early intervention, outreach and engagement, workforce education and training, capital facilities, technology needs, and innovative pilots and projects. I do want to lift up that innovation is mentioned across the board. It is specifically also mentioned in this bucket. So the majority, or 51%, of these resources do need to go towards early intervention. And that's really to recognize what you have all done so much to advocate for, which is we should be aggressively serving people who are at their first engagement with, engagement's not the right word, but experiencing their first mental health break, challenge, etc. Really go at it with gusto to make sure that we disrupt what is that known spiral, unfortunately, that can take someone down into having a very serious and persistent mental illness or substance use disorder. So, and again, these are 51% of that 51% requirement does have to be for young people. I can't even read that, but I know how much you guys are interested in this topic, so I'll look at it right here. I think what I wanted to make sure I did in today's presentation, and do a time check, okay, is to really make sure that we walk through, in particular, the early intervention section. We worked really hard on this, and I think and hope that it reflects a lot of what we've learned in doing this work over the last decade plus in particular. The section itself is still very similar to the original section. Talks about the need to emphasize these kind of what we call, I know we're trying to be more positive, but they are still the negative outcomes associated with untreated mental illness, suicide, self-harm, now with SUD it's overdose, incarceration, unemployment, homelessness, prolonged suffering, basically school suspension, expulsion, referral to alternative schools, community schools, or failure to complete. We made sure that we lifted up that this could be as early, it kind of breaks my heart to have to say this, but as early as 0 to 5, and inclusive through higher education. Removal of children from their homes, that's one of the original ones. Mental illness in children and youth from social, emotional development and behavioral needs in early childhood, including outreach to education, including early care and learning, so that's inclusive of our 0 to 5 partners, through secondary school. Reducing disparities, that's an original. Expand community-defined evidence practices and evidence-based practices, that's a new one. And lifting up here, and I think I mentioned this before, but that the OAC in partnership with our Department of Healthcare Services will also consult with counties and stakeholders to establish that biannual list of evidence-based practices and community-defined practices that may include practices that are identified as part of our Children and Youth Behavioral Health Initiative. So as you know, right now I'm not the Children and Youth Behavioral Health Initiative Director, so I'm not gonna have the super details, but we've put out a significant amount of grants to expand knowledge in this space, both for community-defined practices and evidence-based practices. This potentially could be a funding source to sustain that work if it is effective, or, et cetera. Another thing I think is really important is we lifted up in this section that counties may act jointly to meet the requirements of this section. Again, I think it's an innovative thing that counties can do. I don't have a particular example that I'm thinking of in mind, but there might be something that they want to work on together, especially those counties. I think about the cluster of counties in the Bay Area where I'm from that are so close together that may make sense to do a project together. Maybe they share a university or a community college, et cetera. So those were kind of some of the goals, so to speak. Here's some more of the priorities. I know you guys have played an important role in this. So I'm going to actually walk through them. So strategies targeting the mental health needs of eligible kids, 0 to 5, including but not limited to infant and early childhood mental health consultation, early psychosis and mood disorder detection and intervention and mood disorder programming that occurs across the lifespan, outreach and engagement strategies that target early childhood, 0 to 5 years of age, inclusive of out-of-school youth and secondary youth, partnerships with community-based organizations and college mental health and substance use disorder programs may be utilized to conduct these strategies. There's, again, strategies to advance equity and reduce disparities, including culturally competent and linguistically appropriate interventions, strategies that target the mental health and substance use disorder needs of older adults, programs that include community-defined practices that have been successful in reducing the duration of untreated mental illness and substance use disorders, strategies to address the needs of individuals at high risk of crisis, and other programs that are proven effective in preventing mental illness and substance use disorders from becoming, that term from the original MHSA, severe and disabling. Again, lots in there, lots to really focus on in terms of really trying to disrupt the onset of a major debilitating behavioral health condition. So I hope that was helpful, really diving into some of those details. I think we have one more section in here. Okay, program focus. So broadly, the program focus for early, yes. Oops.
Okay, I'm sorry. No, please go ahead.
Broadly, the program focus for early intervention is outreach, access and linkage, and services. And this, I think, is really important because I think there was a lot of concern that there wouldn't be an ability to do a lot of outreach and engagement. So outreach to families, employers, primary care providers, behavioral health urgent care, hospitals, emergency departments, education. I'm not going to read them all, but all people who might be in a position to recognize the early signs of a potentially severe and disabling mental health or substance use disorder. Access and linkage to medically necessary care that's provided by our county behavioral health partners early in the onset of their condition, mental health treatment services that may include services to address first episode psychosis, mental health and substance use disorder services that demonstrate an effectiveness, again, to meet cultural and linguistic needs of diverse communities. Mental health and substance use services that may include services to prevent, respond, or treat a behavioral health crisis, mental health and substance use disorder services that may be provided to children and youth experiencing or at high risk of trauma, child welfare or juvenile justice system involvement, and/or homelessness. So, a lot to chew on there. Now we're going to focus on population-based prevention. So the state takes on a new responsibility in providing population-based prevention. This will be administered by our California Department of Public Health in consultation with you and our partners at DHCS, of course, also all of our county partners and others. But 51% of these funds have to also really be dedicated towards, and this is a have to serve people 25 and younger. So let's see. This particular slide I wanted to pull out for you all because I know how much you have advocated for school-based and school-based care, but also using our school partners to really prevent and promote early access to treatment and care. So this talks about school-based prevention support programs that can be at a school site or arranged by a school, not on a school site. Again, I think the golden rule in this population-based prevention is that the intent is not to do an individual intervention, but a school is not necessarily considered an individual. So I'm going to move on after that. So population-based, some of the details of our population-based program, they're intended to reduce the prevalence of mental health and substance use disorders. That's a new one, but that's really a population health-based strategy. To promote evidence-based programming and community-defined evidence practices that meet one or more of the following conditions: that they target the entire population of the state, county, or a particular community to reduce the risk of individuals developing a mental health or substance use disorder, that they target specific populations at elevated risk of a mental health, substance misuse, or substance use disorder, that they reduce stigma associated with help seeking, that they target populations that are disproportionately impacted by systemic racism and discrimination, and that they seek to prevent suicide, self-harm, and overdose. Population-based prevention programs may be implemented statewide or in a community. Population-based prevention programs shall not include the provision of early intervention, diagnostic, and treatment services for individuals. And then early childhood programs for the 0 to 5 shall be provided in a range of settings. Oh gosh, it's a lot, isn't it? Moving on to workforce, we're almost done, guys. So new state responsibility again. I guess what I'd like to really share in this story is doing all the work with CYBHI, which was our first ability to get a substantial investment in the behavioral health workforce under this administration. It really was a challenge because to really expand the workforce, you had to expand the ability to train people. You had to have more professors. You had to have more slots in schools. And that's really just focusing on certain types of people. But now that we have a sustained funding source, I think really reimagining how we train the workforce of tomorrow and building the actual capacity to do so can be realized. So very excited about being able to work on that. And then the last piece of all the different components of the BHSA is innovation. And so this is the piece I was talking about. The mechanism to assess how this is being done at the local level is through the county integrated plans, and they must demonstrate how they will strategically invest in early intervention and to advance behavioral health innovation. And then that's just simply a repeat of what we've talked about before in terms of the Behavioral Health Innovation Partnership Fund that will be managed here at the commission. Whoops. So some, I think that must have been like a hint. I jumped to the last slide in this section. Everyone's fallen asleep. So this is really an important part. Again, I have a couple of slides in this space, so bear with me. But there are significant changes to the county integrated plan. The things that remain the same is it's still a 3-year plan. There's still a local, robust community stakeholder process that has in many ways been enhanced. And they still go through local advisory boards. They are still attested and signed off by the Board of Supervisors. I think what's significantly different with it is that it really tries to bring all of the sources of funding that in particular the county specialty behavioral health system has. So obviously there are BHSA funds, but also there are opioid settlement funds, there are SAMHSA funds, if they have a PATH grant, realignment funding, FFP, things like that to really share the whole picture of how a county is funding all of its plan responsibilities. And so you'll see there that plan will include their expenditures, their reserves, adjustments that they've made. Obviously, very important on the program side is all of their goals and the outcomes they intend to achieve, and we'll talk about the mechanism to actually have those outcomes reported to us. And these are also going to be developed with population needs assessments that are conducted by our Medi-Cal managed care plans and in collaboration with our local health jurisdictions who put together community health improvement plans, really recognizing the whole health aspect to this. And as I mentioned, you can go back and look in the statute of all the additional stakeholders who are required to be a part of the planning process. This, as my colleague at DHCS refers to it, the integrated plan is like the what and the how. This is the plan that is, this is the impact plan. This is the report that says, well, we really spent this and this got this outcome. And so both of these are things that we'll be working on with our county partners to design, obviously as directed under the statute. The one thing that I think is substantially different is that if counties are not meeting the, I don't want to say benchmarks, but let's just say that DHCS is authorized to impose corrective action plans on a county who is failing to meet certain requirements. Maybe they're not spending a quarterly in a particular bucket, et cetera. The plans and reports have a lot of data requirement. It was one of the reasons why we felt it was so important to support counties and having more resources to dedicate towards completing and conducting these plans and doing this kind of reporting. It has a lot of different indicators that may show the kind of what I would say kind of the health of the system. So how many people in your community are incarcerated? Is that number going down? How many people are experiencing homelessness? We have a lot of work to do about developing a set of metrics that make sense, but there are a lot of creative things that we can do that really are going to show the health, I don't know, give us a picture of what's going on in the community, and also to help support that community on where to prioritize their resources in order to address those issues in their own community. There also is this additional process of oversight of this process. Obviously, we're doing an enormous amount of change, and change is hard and difficult, and sometimes it's messy. And so I think it was, with the wisdom of the legislature, they wanted to have a state auditor report component of this. And so here's some of the things that audit that will kind of follow us. For the first, our first report is due the end of this decade, and then every 3 years after that until 2035. So that's really basically like a 10-year tail to show us or try to assess whether or not we're making progress with this massive change. And you can see all the things that they'll be taking a look at. And I think this is pretty much the end. I wanted to lift up for you that we are very cognizant of the areas of which you need to engage with us, and we need to engage with you. So these are areas in which our department will be consulting with the OAC. I've mentioned most of these throughout the presentation, and so I don't know if I need to say them again, but maybe a few that I did not mention would be, again, like I just said, developing those statewide outcome metrics, determining statewide behavioral health goals. You, of course, working with our Department of Public Health on the population-based prevention program, working with us to identify allowable sources of fund or how we want to use that innovation partnership fund. Also want you to be working with us as it relates to our other two departments, CDPH, so public health, and our healthcare access. I can't even remember what HCI stands for. I'm so sorry, HCI, if you're out there listening, I apologize. Healthcare access and information. Yay. And lastly, there's some information about some collaboration that we want to do on just overall promoting transformational change through the research, the evaluation, and the tracking of outcomes that we're now going to be able to do because we will be collecting more information. So I don't think this is really all that exciting. Okay, so this is the place to go if you want to receive more information. We are really building our capacity to put out some more public-friendly information. Obviously, the presentation I just gave was extremely dense. It was definitely tailored for this audience. I wanted to make sure you guys really had a chance to absorb the pieces around early intervention and prevention in particular. So we're looking forward to doing more, and I'm going to stop there.
Thank you, Stephanie. Take that breath. Can we get you some water? Anything? Okay. Thank you so much. That was a lot of information and really appreciate your time here. And at this time, I am going to open it up to commissioners for questions, comments. All right, please, Commissioner Danovich.
Yeah, a couple questions, but first let me let you sip that water. And as you do, thank you. Really, really tough to synthesize and deliver all that in a succinct way as you have, and appreciate the presentation and the work and the plan to continue to engage and work together with us. The questions both relate to things that you've touched on, but that I think are really important. You know, one is the piece around the transparency report, which focuses on, I think the examples are kind of spending and services. But I think there's also the desire, of course, to have patient outcomes. When I think of an analogy, I think it's not a perfect analogy, but a recent one at least, you know, COVID, when we had to transform an existing healthcare system to respond to a current crisis in prevention and early intervention and severe disease. You know, we used real-time data on patients and the symptoms they had and the response to the symptoms and the severity to really drive awareness of where we were performing and where we weren't and how to make the system work. We have for a long time wanted to have that kind of data. What has prevented it? What can DHCS do to help facilitate our getting that patient-level outcomes data that we can use to drive awareness of where are the disparities, who's performing well, you know, which regions are struggling, and how can we hold all of the spending and services accountable to be driving the change there that we all want to see.
So I think some of that is probably for my colleagues at DHCS to answer in more detail, so I'm taking detailed notes so that we can get back to you. But I do think part of the problem, and maybe even my county partners in the audience or in the ethers would agree, is we have really antiquated systems, data systems. The actual technology is a challenge. And so I think that one of the things that we're really hoping to have the capacity and resources to do is to really invest it in reimagining those systems. I'm speaking for us, in order to accept that information, so to speak. I can attest to the deep interest in having something like more real-time data on patient outcomes. I obviously work at Health and Human Services, and people learned so much during COVID because of the, frankly, life and death situation that we were in terms of needing to know how to pivot. And so it is inspirational to figure out how do we do that in our own system, what makes sense, and really honestly to support our locals to have that information and to understand from them, they're the ones who are doing the care directly. I'm sure that they would be just as interested in us in having the ability to have more access to that data to inform their own work as well. So lots of that's not a very detailed answer, but I do think that's one of the areas that we want to work on you guys with. So maybe you'll be the one who volunteers for that work group. We do have to develop those statewide metrics.
Yeah, I think that it's urgent. It's a burning platform, because to facilitate everything else, we have to be able to have a measure around which to incentivize change. And I think that the measures exist. They're known. They exist in repositories. But as I don't need to tell you, like that the data is siloed.
Yeah.
And so we have to overcome that. But if we don't prioritize that, everything else is going to hinge, on it. The second question is related to that, which is that transforming the system in the way that we need, the devil's in the details on everything. Or if we can achieve everything that you've outlined that is the vision, we can all, sleep and rest happy at night. One particular area that's close to me is substance use disorders. And it's so heartening to see the focus on addressing substance use disorders. And again, the devil's in the details, because our service delivery system is still very separated, and the ability to deliver on the objectives there are innumerable barriers. So how will DHCS and how can we support you in lifting up kind of the barriers to develop strategies around addressing them from the outset? Because we know we can anticipate that where these objectives are going to get encumbered in the same sort of challenges that they've had to this point.
So I have heard in other people's conversations that one of the really positive things that people see in this is not just the inclusion of SUD. The fact that SUD is included in the BHSA is something that can really catapult efforts around integration. And so I think because we had this like really important funding source that was like blocked off from being able to serve a population unless you had a co-occurring disorder, which was a really insightful change that was, amended the MHSA a few years ago, but it still had to be a primary mental health condition. So I just want to acknowledge that we recognize that that's an area. I mean, I think last year I would have been here with my colleague, Tyler Sadwith, and this is a passion of his, and he's now our state Medicaid director. I feel like it'll be front and center. I don't know the what yet, other than I think this is a forum where you can bring to our attention ideas, innovations, people being creative. I think you guys might even be doing a little bit of work in this space. I'm not sure. Yeah, I don't know if that answers your question, but it is definitely a priority that we're thinking about. There's a lot of work in this space to just build out and modernize our SUD delivery system.
Thank you. Commissioner Robinson, please. And then Commissioner Chambers and Commissioner Brown. Thank you.
Thank you. Really great presentation. Appreciate the detail and distilling a really complex initiative into the time you had allotted. One of the areas I'm concerned about, and probably have the biggest concern, is around workforce development. And this initiative is hinged on us having people to deliver services. And we know that we don't have enough healthcare providers already. But the ambition of this initiative will be for naught if we don't have people to deliver. So I'm looking at the investment we have in workforce. It seems meager relative to the size of what the needs are. So just I appreciate your thoughts about that and how we're going to address that in a meaningful way.
So one thing that I can offer, I know that in another place in space, we're thinking about putting on some sort of like an educational forum just to bring everybody up to speed with the 2 workforce initiatives that we have underway right now. We are starting to see the results of those. I think I just don't have the numbers in front of me. We had the $800 million that was dedicated through the Children and Youth Behavioral Health Initiative, and then we had, of the $2.1 billion that was for the Healthcare Workforce Initiative, there's a good chunk of that that is for behavioral health. So I think that's one piece, is just to, like I said in the beginning, and it's probably a neglect, although I'm sure you did not want my presentation to be longer, to talk about some of the investments that are starting to materialize in our workforce space. But I think it's not going to just be about more people. We're not ever, it's kind of like how I feel about crisis. Like it has to be different people. It has to be ways in which we are working more efficiently, looking at different types of people to do different things. I can't even remember where I was yesterday, but we were at our 988 advisory committee and learning about the just incredible role that nurses can play on outreach teams in terms of, and they are and have special training around psychiatric, how to be a psychiatric nurse, and the things that they can do in terms of providing other services, I guess. And so I really do think that as part of this process, and we have an amazing person that we recruited to lead our workforce efforts, who came from outside of state government, working on an initiative internationally for the Clinton Foundation around just reimagining who can work in what space. And so I do think that's an incredibly important part of it. I think definitely want to assess what everybody's doing now, and are there ways in which we can build upon things that we've learned. Wanted to share, because I think that'd be interesting for this audience, that we have just shy of 1,000 people registered to become certified behavioral health or wellness coaches. And so that was a project that, I don't know, we started fairly recently. Maybe it took a couple years. So I think we just have to be thinking about the creativity that this group is really interested in as well. How do we bring in other partners to help us do things faster? Create this workforce faster. And again, I do think that because we have a sustained funding source, we might be able to engage some partners in different kinds of conversations because they can make a long-term commitment. Maybe it's something we can talk about in having a follow-up presentation, because I think that things are starting to materialize now that we're in year three or so, at least of the children and youth behavioral health part, obviously the wellness coaches, but also, advancing slots and things of that nature. It takes a while to develop a new person, but I think it's important to look at our current workforce.
Commissioner Chambers, please.
Thank you. I'm going to refer to this, assume this dovetails with the PowerPoint presentation. And thank you. I really appreciate it. I did not fall asleep on any of that. It was all interesting. Of course, I represent peers and family members, so my lens is going to focus on that. On the outpatient care, I appreciate the investigations and parity, the commercial plans. However, the peer workforce is not included in that workforce, so I find it troublesome for people to continue to highlight like how great peers are and how they're doing all this work, but we're still not able to practice anywhere outside of opt-in behavioral health. So these are just comments, and then you can have reflections. The next one was I saw on crisis care. There's which is great. I believe in this program. That's why I'm highlighting it. The success of the CalHope program. I 100% will let you know that I don't know how a person in California got my personal number, but a person called me looking for CalHope resources last week, lonely individual, and they just needed someone to get low barrier access into care. That program has been threatened to be cut at least 5 times. 6 times it's going to be cut in April. I don't know what parts are being funded, but I for sure know that that program has been cut a number of times and it's not been stable, which has created instability for providers and for Californians who need still low barrier access into care. And the other systems is important, but that's another thing. And then in the inpatient care, which is great, I just really would like to work collaboratively to ensure that there's transitions out of these places because people are stuck in these facilities, and just a report that just came out of folks being stuck in these facilities. And as we focus on these other systems of care, ensuring that there's places for people to go when they get out of the hospital, and community-based peer organizations, somewhere to help them function in society. And I just honestly want to just put that on record that we should commit to community-based services and transitioning folks out, and do not leave out the organizations that prop up those individuals when they get out of the hospital, especially peer-run organizations. And then I think to that whole point is these highlights of CalAIM, which is amazing. I was so excited to see how, we're putting this emphasis on the health plans to focus on the justice involved, homeless population, but yet and still those folks would not be eligible, some of them, for peer support specialists. So I don't know how we could work in these systems so that we can get individuals a peer support specialist throughout Medi-Cal, because I think it's a benefit. So those are just reflections. I don't know if there were questions, but I really uplift the work that you're doing, and I look forward to continue to lift consumers and family members, because we are an integral part of getting people into treatment, ensuring the therapeutic alliances, adherence to treatment planning, and supporting people when they get out of the facilities. Thank you.
Can I make one comment in response? And those were all excellent comments. I'm taking notes. I will look into I don't know the answer to the CalHope question, but I have seen, and it's been very positive, some conversations about trying to think about what I think Commissioner Robinson, who's no longer sitting there, I don't think, was talking about the value of really looking at using different types of folks in the workplace, especially as we try to have maybe some different types of services. So, systems are, it's hard to change systems sometimes. It takes a little bit of time, but you guys have been tremendous advocates. And I know we had this discussion, our behavioral health task force with some of the health plans around the value of peers. So it's being heard. And then I just want to concur with you that, and I shared this in a budget hearing earlier this week when we talked about the behavioral health continuum. And I will leave, because I love the story, and I do think it's what you're talking about, but I have an 80-year-old mother who had double knee replacement surgery, and I'm not strong enough to get her up and down 5 stairs or even do some of the other things that were basic support for her. She was able to go to a rehab hospital for 30 days. And while she didn't really want to go at first, she knew that she would get intensive treatment so that she would be able to walk down those stairs with some assistance and come home and be on a more rapid recovery because she got that intensive treatment. And I would say that that's something that I really want our system to be able to do for people, because if we're able to really invest in supporting someone to recover from a traumatic crisis or some sort of break in their mental health, maybe they are able to get back to work. Maybe they're able to not lose their employer-based insurance. And so what a great thing to strive for and to utilize peers and family members and other people to do that work. So thank you for sharing that.
Thank you, Commissioner Chambers. Commissioner Brown and then Commissioner Rolette, please.
Thank you, Madam Chair. Thank you, Stephanie, for a great presentation. A lot there, and you did very well. I do want to just bring to your attention some concerns about part of the crisis care element of the plan and what's happening now, particularly with respect to the guidelines and the regulations that have been issued that provide that Medi-Cal funding is not available for crisis response teams that include a law enforcement responder. And that's even not available for the behavioral health element of the co-response team as well. 37 of our 58 counties in California have some form of law enforcement behavioral health co-response. And the DHS directive and the guidelines and the regulations seem to be an interpretation of a federal recommendation from the Centers for Medicare and Medicaid. They're not requirements, and in fact, other states do not have this restriction for teams that include a law enforcement co-responder. We in our county have had great success with our program. It's very popular amongst a variety of different sectors within the community, including especially families of people that suffer from serious mental illness. And we've had great results as a result of the program. And I know that there's this push to go to teams that do not include law enforcement. And we've seen recently that Los Angeles is in the process of shutting down their program where they had paramedics responding with mental health professionals and have had poor results from that program after a couple of years with no freeing up of first responders, no freeing up of emergency rooms and other objectives that they had for the plan. So I've written a letter to your boss asking for some clarification, and if you can just carry that back and put it on the radar of not only DHS, but also to the governor as well, that this is something that I think really needs to be rectified. I think it unduly is biased against law enforcement involvement in a very positive way in what's happening in crisis response in some communities. And there is no cookie cutter approach. Some, it may not be appropriate, but we and other counties have proven that it is a successful mechanism.
You have my word that I will bring that back.
Thank you, Commissioner Brown. I have Commissioner Rolette, then Commissioner Gordon, then Commissioner Carnevale, please.
Hi, Stephanie. How are you? Stephanie and I get to intersect on lots of committees, primarily because Stephanie directs my time and tells me what committees she wants me to volunteer to be on. And so part of my question is related to population health management and payment reform. And again, we've embarked upon what I think is a very necessary transition to what I believe my fellow commissioner was pointing at, and that's value-based care. And as we do that, I've experienced that managed care plans and community-based organizations are intersecting a lot more, nonprofit and for-profit community-based organizations. As it pertains to the mild to moderate population, and you referenced that, there are, I think, additional strategies that the state or even mandates the state could impose around transparency, risk sharing that would enhance the beneficiary's experience. The goal there is for the beneficiary to have greater utility of their benefit. If I use my benefit, I know how to use my benefit better, it will reduce the inappropriate utilization of different types of health care. I don't have to go into the emergency room to get my health care treated. And that requires, in my opinion, greater transparency and more collaboration. So if there are, and that, in my opinion, again, points to risk sharing. If there are things that the administration can do to say to those plans, hey, let's convene together and talk about what's working specifically as it pertains to ECM and CS and what's not working, I think that would be great. And another funding source that's associated with all that is the state-sided funding, which is, again, a great opportunity. And it leads me sort of into my second comment. What I hear from DHCS is that we have brought into California a variety of different types of funding or opportunities to access funding to ameliorate the behavioral health dilemmas that our state is experiencing. I don't always experience that when I hear from counties. And so it might be helpful, and I know that the executive director of the County Behavioral Health Directors Association, Michelle Cabrera, recently did a presentation for the Planning Council to have her come and present to us to hear her perspective about that. Because, again, I'll go now to my specific question. You talked about outpatient funding, and that got my attention when you talked about utilizing funds from the FSP bucket. And there are, it's not page number, but it was the Full Service Partnership 35% FSP bucket. And that for those individuals that are being served in the outpatient system, county-funded outpatient system, that the county might, and I think I understood it, but that's why I'm asking the question, that concerns about their funding for their services might be ameliorated because they could utilize some of the dollars in the FSP bucket. And that was a little bit unclear to me. I don't know that that's exactly what you meant, but that if you could make a point of clarification about that, that would be helpful. And then lastly, my last question is, again, I'm going to go back to the accessibility of data to inform services as we advance in implementation of this. And one of the things that for those of us who've been around a long time, the ideal was that we would be able to use data to objectively inform the service provision over the course of years. And it's been articulated better than me by Commissioner Danovich. But if we, again, with the hope is that we will be able to access data in a timely manner to really inform service delivery and make some of those critical adjustments. So I'll pause. Those are my comments. Thanks for the presentation and the time.
So a couple ways to answer your question. One, it's challenging to talk in hypotheticals because I don't know which county you're talking about or what the actual outpatient program is. So I'm going to talk about what the statute says. So first, FSPs will have levels. And when someone says that someone's in an outpatient program and they're in a clinically enriched field capable based services outpatient program, to me that seems like that potentially could be a level of an FSP. And so in the way that we're thinking of levels of FSPs, if the top level of an FSP is an ACT model, the most intensive, low caseload, people with the most serious and persistent mental illnesses are in that ACT model, which I think the caseload is like 1 to 10 for an at-Fidelity ACT program. We know that people don't always need to be in that, and they certainly shouldn't stay in it for their lifetime. So I think this is why we want to work with you guys. We want to work with, DHCS is intending to have a whole work group process around what do those levels really look like, because I know there are people who are going to be enrolled in an FSP and getting services in an outpatient setting. And I do want to emphasize that these are people who have to be enrolled in an FSP. Now, I don't know what counties are saying about their outpatient services, but what the law says is that if someone is enrolled in an FSP, that they can receive outpatient services, either clinic or field-based, if it's necessary to keep them stabilized. And from what I've heard, that's exactly what many counties are doing. So I really look forward for us being able to roll up our sleeves and have detailed conversations about how to make this work to serve people who are the intended target population. I think what we want to be clear about, and I love where you're going, and we should have more conversations, is why are there people that we think that could be served successfully with the supports of ECM and CCS not being served there? So let's have those conversations as part of the planning process that we're going to do. Because again, like I said at the top, it's really about supporting all of our systems to be able to fulfill their target population responsibilities. And none of that's going to be easy and done overnight. It's going to be challenging. The cost of healthcare is going up dramatically while we're sitting here. I think our OCA meeting is going on right now. And so we really have to think about how we can be successful in all the systems. So that's not answering your question about metrics, but I don't know if I can answer that question, but I have taken that down. But I understand exactly what you're saying. I mean, this is nothing new. I mean, Al, and I could go back 15 years where we were having conversations about how could we have real-time, from a more clinical perspective, how could I have real-time data that would actually help me better think about how to serve the client that I'm working with. So we'll take that back. Exciting. Okay.
Thank you, Commissioner Rolette and Stephanie. Commissioner Gordon, please.
First of all, thanks for the presentation, Stephanie. Very, very, very thorough. I also want to give a shout out to your team at DHCS and HCI, and all the work that's been going on has been amazing and very, very promising. And I think it's very encouraging that the governor and your teams have been pushing on this, and it will make a difference. I think adding SUD is brilliant, and that will make a difference. What I'm concerned about is, I know the data is very important, and data is not something the state typically handles well, but I think if it takes more resources to get an operational system working better for this effort, it's more than worth it to invest more in that. The same thing with workforce. I think what's being done there may be an underinvestment in that, because I think that's at the heart that's at the heart of the matter. But I think we're happy to help on all of that. The final point is, I think the thing we're finding that is the biggest barrier is the lack of access to services, particularly in our underserved communities, and particularly where it bears on the 0 to 5, 0 to 8-year-old space, where the real prevention can occur. And I think whatever we can do to move that aspect of this initiative more boldly. I know there are many groups that are invested and interested in that, but I think that should be a real priority. I think the schools are in a position to help with that because, as much as it takes building relationships with people to make them trust the system and come forth for treatment. A lot of times the services are remote, they're not accessible. But it turns out there's a school in every community in the state, and there's a set of relationships built around that school, which are trusting relationships, which are a good start toward bringing better access at a much earlier point. So once again, whatever we can do to support the effort, I think it's amazing, and I think it will make a difference 5 or 10 years from now. I think this will look very different, and thank you for your efforts.
Thank you, Commissioner Gordon. Commissioner Carnevale, then Commissioner Bunch.
Thank you. Academy Award for the presentation. That was wonderful. Really just going to lean in on data again with a comment, which is that it's vital. If we can't measure it, we aren't going to be able to impact it. And as much as this governor has done to lead this, and he's done a lot, we really don't know how big the hole is that we're trying to dig out of here. But rather than a question, I'm going to offer a solution, which is the work we've been starting on around innovation and closing the gap between the public and the private sector. This is exactly the kind of problem we're trying to facilitate solving. So, there is a lot of capacity in Silicon Valley to solve these problems, but we don't really have a mechanism to access it in the way that we need to for government. And we're trying to create what will probably look like something akin to an open innovation platform that will allow us to be able to define these kind of problems and find people who can solve them more rapidly, not the hard way, but the smart way. So I'm hoping that maybe we can begin to solve some of these problems that everybody knows need to get solved, but never seem to get addressed. And that's one of the ways the commission should be able to lean in and help you solve some of these issues. Thank you.
Thank you, Commissioner Carnevale. Commissioner Bunch, please.
Thank you. I'll just reiterate, it was amazing. I never slept. It was a great presentation. I wanted to follow up on Commissioner Roulette's question with kind of a very specific real-world example. I supervise at a very large clinic for LA County, and while we refer all of our clients who meet criteria for FSP to the FSP program, everyone doesn't meet criteria based on the current structure of how FSP is, who actually meets criteria at this point. So for the rest of our very large clinic, it's just considered outpatient. How would the levels work in that example? Or are we going to be looking at changing the requirements for FSP?
So I know that you're probably talking about operating under the current regulations for FSP, or what's in CSS, because FSP is not a concept that's in the MHSA. It's in regulation. So I think without digging myself into a hole and being incorrect, because I'm not DHCS, I think it's come to the work group and figure it out, because the way that FSPs are operated in county by county is different. So I don't exactly know the details of how your FSP is versus something else, but we have an opportunity to design these levels of care that make sense and are in the clinically best interest of the people that you're working with. I don't know who all is coming to your clinic, and if some of those people who come to your clinic would be more appropriately served with the help of ECM. Maybe, I don't know. But I think that we have to figure that out. And, but the FSP that you have today, there'll be elements of it that potentially might be in one of the levels, but I don't have the details to answer that question accurately. But I do know that like I said, we're going to work on it, and we're really interested in people like you that have the expertise, that are working in the field, to help us figure out what that means. But I do think that to be totally direct, I do think there are probably people that are being served by the county behavioral health system that we think potentially could be served by the Medi-Cal managed care system. And so we want to have that conversation. And that's just I want to be transparent and honest about that.
Okay, any other comments, questions from my fellow commissioners? Seeing none in the room. Stephanie, I just wanted to make just an observation and maybe comment. I appreciate the community engagement where it does lift up that County Behavioral Health Advisory Boards must reflect diversity and demographics of the county. I think that's amazing. I just wanted to say that in the accountability piece, where county behavioral health outcomes and accountability and transparency, it says, they will have to report annually unspent dollars, service utilization, data and outcomes, and with the health equity lens, as well as workforce metrics. I'm wondering if maybe the consideration to highlight the disparity reduction component, only because I really haven't seen that. So just a thought on that. I think it would be also equally important to include. And to my fellow commissioners, I'm wondering if we can hear about priorities for follow-up, because, so far I've heard workforce, I've heard about peers in the workforce, I've heard about SUD integration and crisis response. So are there other topics that we would like to follow up on and maybe bring back? And Stephanie, maybe you could help us get the right officials in the room to discuss these things with us. So those are some of the topics I've heard. Is there anything else that you would like us to highlight so that we can follow up and really bring some officials in the room and work with Stephanie to bring the right people in the room to discuss that? So again, I heard workforce, SUD integration, crisis response. Anything else that we could identify?
Chair.
Early intervention. Thank you,
And
Commissioner
the
Gordon.
data piece.
The data piece, absolutely.
County perspective,
The county perspective, yes. Michelle
health
Cabrera.
plans,
The
managed
health
care
plans.
plans, yes.
I would
And
also,
yes, please, Vice Chair Alvarez.
hi, sorry about that. I also just wanted to express appreciation for the presentation, the incredibly comprehensive set of information that Stephanie shared, and was curious if you could share additional thoughts on like the continued conversation on assessing the process, right? Because to your point, Stephanie, this is a huge undertaking and it's brand new. And where there are opportunities for further engagement with the commission to assess how things are going as we move forward, in particular with regard to prevention and early intervention. It's a big shift in moving that responsibility to the state, and what the outcomes of that, what is the impact of that? Again, with a focus on children, on young people, and moving upstream. You mentioned the alignment to Medi-Cal definitions of specific populations, which makes complete sense. And I think really speaks to the department's holistic perspective on mental health and behavioral health. So kudos to that. At the same time, it's those definitions that oftentimes close the door to services and supports for the broader Medi-Cal population that has yet to reach a crisis and is still having the challenges of navigating the necessary community mental health supports and services they need. So what happens? What happens then? And again, just being an open dialogue and identifying those opportunities to connect with county leaders, with community leaders, with the state and this commission to better understand the impact as we move forward. Because again, I want to be transparent that we don't know what's going to happen. But I think we all want to make sure we can prevent serious mental illness. We can prevent crisis amongst all of our young people and everybody. And so finding those opportunities for assessment is particularly important. And then the last thing I want to double back what our chair has said around the need to identify the disaggregated numbers to better understand how we're hitting or how we're reaching our hard to reach populations, our LGBTQ populations, our communities of color, and finding ways to ensure we can improve that. I want to recognize and applaud you, Stephanie. You've got a huge responsibility on you, and you're one person coming to talk to us about a lot of things. And to the extent that we can break up that conversation and bring others into the dialogue, we would greatly appreciate it. And thank you for your partnership thus far.
Thank you. Couple of comments. I do want to lift up that we do require stratified data and strategies for reducing health disparities. So I just want to be clear about that. That was a really important part of the initiative. And then I might have to follow up with you. I'm not sure I understood your comment about Medi-Cal being a barrier to assessment. So that I don't know.
That's not what I said.
I'm
That's not
sorry,
what
I didn't understand what you said.
So you referenced the defined populations for Medi-Cal reimbursement, right? Which actually closes the door to services and supports for the populations that don't meet those definitions. Young people that may not be in crisis, young people that may not be in the system, young people that may not have gotten to that point, that aren't, not connected to the incarceration system, not connected to child welfare. Many times families who want to prevent crisis don't know where to get those services, are having challenges, want to reach community services and supports, and aren't able to do so. I think part of what has been challenging with all of the efforts to improve community-based interventions in Medi-Cal is that many times community organizations don't have the capacity to bill Medi-Cal. Many times they are not familiar with those systems. So again, as we put all of our eggs in that basket of Medi-Cal is going to be the end all be all, which again, I'm encouraged by that. Let's not close the door to the community providers that are actually providing services and supports to a broader population of people that still need mental health interventions. Maybe not therapy, maybe not pharmaceutical intervention, but that still needs some sort of community mental health intervention, and what that looks like, how how those funding streams are sustained. So I don't want to, I want to clarify that that's not what I was saying, but that we need to be clear on how we're continuing to support our community mental health interventions.
Okay, but I need to be clear back that you do not need to be on Medi-Cal to benefit from Behavioral Health Services Act dollars. The provision is if there is a service that can be reimbursed under Medi-Cal, that reimbursement is to be sought. So maybe this is a longer conversation with people who have a little bit more expertise, but I guess what I want you to hear is I'm concerned about the point that you're making, so we share that concern. And I just want to make sure that we're getting you accurate information, because it sounds concerning, and it sounds like new information to me in terms of the fact, especially because we're talking about assessments, that those would be things that would not be eligible. I'm a little under the weather. Sorry about that. And then also, we have said this here before, and as part of our understanding the kind of momentous nature of having to support this work, we recognize that there is work that we have to do to encourage and incentivize and support more providers to come into the field of wanting to be a certified Medi-Cal provider. So that's something that we are interested in working on and figuring out how can we do that? How can we support people to be a part of that system, learn what the barriers are to be a part of that system, and how can we create more administrative efficiencies and, again, incentives to be a part of that system. So I did want to at least respond to that. But I think you're making an important point that we could probably take offline. And then to respond to your interest in engaging with other parts of the administration and to assess the process, we are trying to figure out what that process is and working very hard to figure out that process. You are a part of it, and I just interested in your patience in terms of getting started in that process. But I hear you, and I also want to say, like, this is an important venue, but on a staff level, we can work and do things outside of this particular venue, which sometimes can be really hard to do some of this really heavy lifting and work. So we can explore those opportunities too.
Thank you, Stephanie. Thank you, Vice Chair Alvarez. Commissioner Brown?
Yeah, just real quick, one more addition to the follow-up, and that would be the impact of the expansion of the size of the commission. I'm sure the commission's doing a lot of internal estimates and what have you, but we're going to be moving from a group of 16 commissioners to 27, almost doubling in size. And the budget and the logistical impacts of that, everything from facility adequacy, support staff, reporting requirements, meeting frequency, locations, et cetera, et cetera. There's going to be some thought that needs to go into that, I think, because it's going to have a huge effect. And I'm just looking around the room trying to think, there's 10 of us here today. If there were 27 of us in here, it would be pretty tight. So.
Yes, thank you very much, Commissioner Brown.
And can I just add to that? Because I did write a note, but I didn't want to just take. So I wrote a note because it's like, I think it's great. Okay, the community engagement part, to your point, I might be in the wrong one, but about people looking like the community, like so more diverse youth, Tay, that kind of got to me too, because, and then low income, just other folks that are come from different, maybe not low income, I'm reading the wrong thing, but Tay, when you serve on boards, and I serve on different boards and commission, there is a financial impact, even when there's reimbursement to the state. So I got really concerned about like setting particularly people of color, young people up for color to serve on boards without like support. Like it costs money to serve on boards. It costs money to get reimbursement. Like, I mean, that's what providers. I just want to make sure that the commission is on record that if we say we want to be representative and bring people in, like really be able to help them, because I mean, yeah, I'm just saying like there's a significant financial impact in addition to the reimbursement that this commission already does amazing. Mariani does great, but it's still a lot. I just wanted to put that out there. I hope we get some help with, making sure we don't set people up to not really do the advocacy.
Thank you, Commissioner Chambers. So appreciate that very much. And just when I had asked, I think earlier, what are those pressing topics, I want to just share with you, this is what we have so far. The workforce, pure workforce, FSPs, SUD integration, data, early intervention, county representation, managed care plans, reaching the hardest to reach, and of course our communities of color, and prevention, housing, and justice involvement. Yes, please, Commissioner Rowlett.
Friendly edit, county perspective.
County perspective.
Yeah.
Sorry, crisis response and county perspective. All right, thank you so much. We will work on that. And thank you, Stephanie, again for being here, for the wonderful presentation and working with us as we continue to work forward in partnership. So thank you. With that, we are going to ask if there are any public comments. Mariani, please raise your hand now as the queue will be closing.
We currently have four comments online. We'll begin with Richard. Your line is open. You can go ahead.
Hello, this is Richard Gallo from Santa Cruz, California. I'm a person with lived experience and Medi-Cal peer support specialist. I am concerned about the housing component. I did not hear one thing about peer respite or peer navigation center as part of the housing component. As far as with Proposition 1, peer workers and peers were excluded during the planning without any representation or feedback. We were totally excluded during this entire process. So you cannot say that I heard you or we heard you when it continues to be done. As far as peer workers, currently programs that we have in California may or may not be there in 2026 when the transition change under Proposition 1, because there is no definitions in there about peer workers, peer support in general. It's about no respect, no value from state agency about who we are as part of the mental health community that not only supports our own recovery, but support their recovery, to support their independence, to support their choices in maintaining their recovery. As far as community engagement, we still have counties out there that did not have the buy-in with community feedback. The state and the Oversight Commission really needs to take a stand and not rubber stamp it to penalize them for not having a robust community planning process. This is why the MHSA has failed, because of those counties, those behavioral health directors chose to not buy in to the MHSA principles. I am speaking this as an individual, as a peer worker, and as a Medi-Cal peer support specialist. I am not representing on behalf of the organizations that I volunteered. Thank you.
Thank you, Richard.
Next, we have Ahmad. Your line is open.
Hey, Stephanie. This will be kind of quick because I know we got like 2 minutes and it's a comment session. So it's just consideration for the commission and yourselves. On average, and I can't speak for all the counties, I know there's some colleagues in the room that might be able to speak to it. It does take us almost a full year to do a 3-year plan. We just started in July with planning the planning. I know that kind of sounds odd, but we do plan the planning to make sure what are the venues, how many are we going to do, who are the communities we want to engage, et cetera. Takes us months to do those. Usually by January, we have a draft of a 3-year plan. Then we've got to go through 30-day public comment, getting feedback, getting on board counts, things of that sort. My point with that one is, for us to have a 3-year plan for the next planning cycle, I mean, for a lot of us, we don't look like we have like 24 months. We probably have more like 18 months. And so there's a consideration is the more info and details we can flesh out and more the information we can get would really help, I think, counties. And then doing that, because it's not only are we doing a new 3-year plan, obviously with BHSA, but we're having a transition from one plan and system really to a new one. So we want to have ample time to be able to make those shifts. But also the plan this time around is going to be way more robust. It's going to have different components. We're going to bring on additional partners, needs assessments, things like that. So just making sure that we're giving counties sufficient time and ample time to really do the thorough planning. And part of that, I think, would be just to get as much info on a front end and quicker as possible, which I know you're trying to do as with your presentation here today. The other thing real quickly is making sure that we're making considerations on the equity lens, because I think when we talk about prevention, I know there's that adage, all politics is local. Having worked in the prevention world forever and a day, I know you have as well, Stephanie, it's, I think prevention is local. And so I think it's really making sure that the state or whoever's going to be doing the prevention side is looking at it from the equity lens and having the capacity. Because I'll say, for example, in Fresno, for example, the diverse populations that we would need to be engaging with. We have individuals from Southern Mexico, Central America who have indigenous languages. Spanish is their second language if they speak it. They don't have a written language. We have unique populations in certain parts of the state like Hmong speakers. We have in our rural communities, while they may be Spanish-speaking Latinos, they're of different levels of acculturation and assimilation. So it's like one size does not fit all. So, and I think lastly, and I think it was Commissioner Danovich made the point, of having really access to data and real-time data. That's, I think, been one of the effective things for prevention is being able to address an issue that's arising immediately versus having to wait a couple of years. So things for consideration for state prevention is really being able to be responsive to if there's an issue, a hotspot on a particular issue in an area of the state that we can start addressing it versus having to wait for the next cycle. So just things for consideration, which I know you guys will do. Hopefully we'll get more info sooner than later and we can, work on implementing Behavioral Services Act. Thanks.
Thank you, Ahmad.
Next, we have Stacy. Your line is open. You can go ahead.
Hi, Stephanie. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. Want to compliment you on your presentation. I did not sleep a wink. You are really good at presenting things in a concise way. Prop 1 is so large. I do also want to publicly thank you and Michelle Boss for meeting with REMCO and with the CRDP, the California Reducing Disparities Project, during the negotiations. Of course, we would have liked more, but we really want to thank you for your willingness to meet with us. We just had our annual meeting. You and Michelle were acknowledged at that annual meeting for your willingness to meet with us. So again, thank you. I just wanted to raise some concerns. I know that we need to discuss these at a later time, but regarding community-defined evidence practices, most community-defined evidence practices, frankly, are prevention and early intervention combined. And the current regulations, we're just wondering how CDEPs are going to be funded if these categories are split. So we need to figure that out. And regarding early intervention, the current regulations require a recent diagnosis or at least a person is admitting to or that they are experiencing signs and symptoms. CDEPs do not usually require participants in their programs to reveal personal information of that nature. So again, I know maybe there's easy solutions or maybe not, but I just wanted to raise that. Also, we were very grateful, again, that you and Michelle put CDEPs in more places in the Proposition 1. However, how will FSPs utilize CDEPs? We're a little unclear on that. Again, because of the diagnosis. And also, I think we have some overlapping concerns that Commissioner Alvarez brought up regarding, Medi-Cal requirements. Yes, I realize the MHSA, which we loved, did not require people to be Medi-Cal eligible. However, sometimes the counties required that in order to receive or be in a program or be for an organization to be funded, they had to be Medi-Cal certified. So again, I realize these are complex problems we can talk about later, but thank you so much.
Thank you, Stacy.
Next, we have Laurel. Your line is open.
All right, there we go. Hello, this is Laurel Ben Hamida from Muslim American Society Social Services Foundation and REMCO. I want to say thank you as well for the presentation today and the comments by the previous speakers are important. The one item I want to focus in on is data. So the census will now be collecting a new category of demographic data, Middle East and North Africa. People of those descents, and it's a bit complicated, it's a colonial heritage, have been in the US categorized as white. That is because when people from Syria and Lebanon, so on, first immigrated to the US, it was at a time when Southern Europeans were very stigmatized and they did not want to be categorized as Southern European, Middle Eastern, they wanted to be considered white. But things have changed and there's been a move to have a new category, MENA. So not only is the census going to have MENA, but there is a current bill, AB 2763, the California MENA Inclusion Act, which is on its way, hopefully to the governor's signature. You can follow it if you like. And so that will have relevance to what were PEI requirements and training. Now, depending on how things are divided up, but still with requirements, MENA may be a new category that everybody needs to become aware of who's involved in data collection and data analysis. Training may be necessary. So I wanted just to mention all of that today. And it will apply, I think, to the innovation coming up if I'm not able to make public comment at that time. I think in our community, we will have questions about PTSD and whether that is considered along with psychosis, how it's going to be handled, because we have potentially, we think of almost everybody who enters from a war or conflict zone as being at risk for PTSD, and that is not something that depends on a particular age or genetics. So thank you very much, and look forward to the presentation on innovation.
Thank you, Laurel.
That was our last Zoom comment, and we have one from in the room. We have Michelle Smith.
Okay, there it is. Oh, that's really loud. Sorry. Good afternoon, Michelle Smith. I am from Orange County Behavioral Health Services. And so thank you so much, commissioners and Stephanie, for being here today and for your time. What a great presentation. We really appreciate you sharing the vision of the state. It's actually very helpful for us to be able to see that and to know that we are kind of on track in our interpretation of how we see things moving forward in the state. And as counties transition to this updated framework and our system redesign, and I know Ahmad kind of touched on this, I'd really like to touch on the importance of receiving that information from DHCS as soon as possible in terms of being able to begin our planning and have guidance so that we can have meaningful discussion with our stakeholders. As an example of a large county such as Orange, we have to start planning now. We really have to have, in order for us to not just have like an MHSA plan, but an integrated plan that includes everything. All of our BHSA funds, our SUD component, our sub-G, our mental health block grant, our realignment, like all of those things integrate into a plan. First of all, please consider the accessibility of that level of information for our communities. Right now, our MHSA plans are anywhere from 200 to 600 pages, and it's very difficult for folks to understand the services and the programs and what's going on. And so please, I urge you, please don't make us put together 1,000 pages. I know that sounds really trite, but please take that into consideration. I also am hoping that we learn a little bit about how the MHSA all those years ago was rolled out and how we got the information and the guidance per component. And I think that as a lesson learned, that may have contributed to kind of a segmented implementation of the MHSA, where it was almost as though prevention and early intervention was living outside of the system of care. And so if we can make sure that we take that integrated approach right from the beginning in terms of that guidance, that would probably be very, very helpful to not just counties, but to communities, so that as we engage in planning, we're looking at the entire system of care. We just want things to be implemented in a cohesive way so that we make sure that we're meeting the vision of the state, meeting the vision and the needs of the counties. And that was just really all I wanted to say. So thank you again for affirming that the plan is to provide that guidance in January 2025. And anything that you can leak out to us ahead of time would be really, really appreciated. So thank you.
Thank you, Michelle.
That was our last public comment.
Thank you, Mariani. Stephanie, again, thank you for the excellent presentation, and we look forward to working with you in the future. Lots to do. All right, everyone, we are going to pause for a lunch break. We will break for 30 minutes, so we'll see you back here at about 1:05. See you then. All right, at this time, I would like to turn it over to Toby Ewing, Executive Director at the Commission, to start off this conversation. So Toby, please go ahead.
Thank you, Madam Chair and Commissioners. So one of the changes, and I should say that Deputy Secretary Welch was not able to stay for this, but they're monitoring the discussion. There are a couple of changes in the Mental Health Services Act as it transitions to the Behavioral Health Services Act related to innovation. And so we wanted to put this on the agenda to engage with you in a discussion about the opportunities moving forward. And as outlined in the tab, there are really sort of three issues to think about. Under the current statutory structure, the counties are required to set aside 5% of their MHSA funding for innovation. And as you know, that in order to spend that, they have to receive permission from the Commission. That 5% set aside expires, but there is language in the law that requires counties to invest in early intervention and to advance behavioral health innovation. And so there's a sort of a general expectation that innovation will continue to happen. And the Commission has learned significantly over the years about innovation and how to support that. And so we have an opportunity to talk with our county behavioral health partners about what that means moving forward. So that's one item, is how might the Commission continue to support the ability of the Commission, of the counties to pursue that innovation strategy. And if you're looking for that, it's in the primary packet. There's just a one-page insert under item 8. The second component of this shift from the MHSA to the BHSA is innovation doesn't go away. The local fiscal set-aside does expire, but the Commission will receive $20 million a year for innovation. The statutory language requires that for the first 5 years, with an opportunity to extend that beyond that 5 years. So in essence, the Commission will receive $100 million to support behavioral health innovation. And that's consistent with the conversation that the Chair has asked Commissioner Carnevale to lead in terms of how best to use those dollars. So we have an opportunity to prioritize the $100 million and leverage that to support innovation broadly defined. The third item to think about, that we're asking you to think about, is recognizing that as counties, as California shifts from the MHSA to the BHSA, there is a balance of MHSA innovation funds that are still available for expenditure. And the way the Behavioral Health Services Act is structured, it allows counties to continue to use those funds for Commission-approved innovations even after the BHSA takes effect, if they were approved by the Commission before that deadline. And we have, working with the counties and with DHCS, we have estimated that there's about $250 million of new MHSA innovation dollars available. And there's somewhere in the range of $800 million of previously approved innovation funds that have not yet been spent by counties. Some of those are in active projects that counties would need to stop pursuing if they wanted to repurpose those funds. Some of those are in Commission-approved innovation projects that have not yet begun. And the Commission's rules have long recognized the need for counties to be able to revisit innovation decisions if a project was no longer a priority or wasn't working out as they had envisioned. We certainly didn't want to create an incentive for counties to spend innovation funds in an approved plan if they decided that their initial plan wasn't working out. We wanted them to fail quickly, so to speak, in terms of revisiting that. That $800 million figure is based on financial reports that are a couple years old, so it's probably lower. But generally speaking, there may be up to $1 billion of MHSA innovation funds in the queue. Because the law the BHSA allows counties, sort of grandfathers in those decisions, counties will have a couple of options. If they don't use the money for innovations, those dollars roll forward into the new spending categories under the BHSA in which innovation is eliminated. If they want to dedicate them for innovations, per your authority, you can approve those innovations for really any length of time. And so typically the standard has been 5 years that you've approved an innovation plan. And so we wanted to have a conversation about the viability of prioritizing or encouraging the use of these last sets of innovation funds to support the ability of counties to transition from the MHSA to the BHSA. And there's a couple of reasons for that. In particular, the analysis that staff does with counties in response to their innovation plans, per your direction, is to be explicit about how a county would sustain an innovation. And we recognize that an innovation that was planned under the MHSA may have anticipated a financial sustainability plan that did not recognize the new fiscal constraints under the BHSA. And so we are already suggesting to counties as they come to the Commission, as soon as next month with innovation plans, to think about how that investment may or may not align with the new challenges around finance that counties would have to address, with the priorities under the BHSA in terms of transition, and potentially, are the topics that came out of the planning process that might have started 3 years ago aligned with the priorities that counties are facing, not just today, but in 2 years from now when the BHSA rules are fully into effect. So we wanted to just pull off some of your time to talk about those 3 topics. How can we continue to support innovation? How can we use broadly defined? How can we make best use of the dollars? And that's something that Commissioner Carnevale has been leading on. But this big one for staff, and we've placed in front of you a list of some of the county innovations that will come up as we would benefit from some direction, again, as soon as next month, around how to prioritize discussions with the counties on these plans that may or may not align with the BHSA.
Thank you, Toby. Commissioners. Please, Commissioner Brown.
Toby, presumably a big portion or a good portion of this money, the 800 million or thereabouts, is money that hasn't been spent because counties have not been able to, they don't have the bandwidth, or they don't have the staff, or they don't have the ability to start and sustain these programs. And assuming that that continues and moves forward, is there any mechanism, where the counties can either voluntarily or maybe not voluntarily, this money be relinquished to, be able to be redistributed if there are other counties that do it? Because in some ways, it's a curious situation where counties that have done the program, spent the money, been innovative, or tried to be, are not going to have that money, whereas other counties that haven't been quite so innovative and haven't done much are sitting on that money. And exactly. So it's like, how can, in other words, it seems like there's a lot of strings attached with the 800 million.
So thank you, Commissioner. There are sort of 2 options there. Under the state's reversion rules, if a county does not sort of shield these dollars by getting an innovation plan approved by the Commission, then they automatically revert. The state is supposed to take those dollars away and redistribute them to other counties. And so that's how reversion is structured to address the very issue that you've raised.
What I'm saying is that, say they had a plan, it got approved, they weren't subsequently in a position to be able to put that plan into effect, they're still not in a position to put that plan into effect and probably aren't going to be likely in a position to put that in effect, especially if the budget situation doesn't look good for the next few years and, you know, they're having financial problems. So how does that, at what point, you know, with the new transfer, or is there nothing, has this not been really thought of? At what point is there going to be some, you know, does that money just stay in perpetuity, or is it, at what point is it brought back into the fund where it can be used?
So it doesn't stay in perpetuity, right? So if the MHSA, if the MHSA was not shifting to the BHSA, it would stay there until it hit a reversion deadline, and then the state would take it away. Or, and this is what we have strongly encouraged, is for those counties who have been unable to make use of those dollars for whatever reason, that they repurpose them using the innovation to come to the commission with a different proposal that is more viable, more urgent, more doable, right? And so we've actively said, we don't want you to lose the dollars, so we don't want you to spend them, you know, if that's not advisable. We actually want you to make smart decisions and say, look, we're just going to repurpose this, right? So we have been very willing and very open to help with that transition. With the BHSA coming into effect, you still have that option of repurposing. Reversion potentially could still be enforced, although we don't know how that will go. And then the third option is any dollars left in the account that are not in a commission-approved innovation plan will roll over and must be distributed into the new categories. And so it will sort of revert within that county outside of innovation into FSP, you know, housing or the other categories that the BHSA lays out. Is that? I believe that's 2026. I'm not, I'd have to look at Stephanie's slides. It's either 2025 or 2026. So it's pretty soon, right? Which is why we're suggesting that, you know, does the commission want to weigh in and signal to the counties, you know, our willingness to prioritize investments that will help with transitions? For example, many of the counties are sharing that their community-based organizations will struggle to seek Medi-Cal reimbursement. And so they're looking for ways that they can help their CBOs prepare for the new reality of BHSA. Might counties be interested in co-investing to build out a technical assistance strategy to help get ready for that transition, right? Many community providers and counties are saying it's unclear how we're going to weather the transition from today's plan to tomorrow's rules in terms of meeting the statutory guidelines for expenditures. And so we've had conversations, well, could you prioritize using your innovation plans to help you do that analysis? Some counties may have the internal staff capacity to do that, some will not or may not. And so might it be useful, again, to co-invest and to do that analysis in ways that will create some comfort and confidence in getting there? How do you wind down what you have and wind up towards the new financial structure that the BHSA is putting in place?
Other comments, questions?
Well, I think that I'm certainly supportive of guiding the counties to appropriately take advantage of the opportunity to spend innovation funds toward these goals. Exactly how and what, and how do we do that tactically? I don't have a specific idea on it, certainly, but there are so many things. Right? The preparing for BHSA, absolutely. I mean, obviously, we've been talking about data, which is a burning. We've been talking about data. That's a burning platform, and a lot of opportunities there. So the short answer is yes, and then would love to hear from others on what some of the low-hanging fruit and opportunities are.
Commissioner Rolette, please.
I hate beginning my comments with a preposition, so I apologize for that. I would direct you to talk to counties and support them with taking unspent innovation funds that ultimately I don't think that they would let revert, and prepare for the new reality. I know that is a bit contradictory to the notion around more innovation, but the notion that, and here's what I need clarification. If they were to develop a different type of innovation plan, would they be able to sustain that effort, albeit we're starting the new behavioral health transformation in 2026? And so if that's a no, and I think it is, then certainly some of the other suggestions, FSP, outpatient, other data-related sort of investments might be more beneficial to the counties, and guidance around how to go about doing that sounds more reasonable to me, given my understanding of the timeframes. Now, if my understanding of the timeframes are wrong, then maybe I have a different comment.
Commissioner Chambers.
Thank you for all the comments from my fellow commissioners. I have been recently talking to some small counties about the transition, and one of the things that came up consistently, even with the previous conversation, the tools that the county is using right now to kind of test how they'll be able to implement it, Prop 1, behavioral health reform. But I still have gotten, even as of yesterday, that they will cut programs. They will cut peer services. They will cut prevention, early intervention. And if I'm hearing that from a county director as of yesterday, I wonder what innovations we could put together or think through. And I don't have the answers, but as a person that represents, smaller providers, people that are on the ground, grassroots, BIPOC, I worry with all the stuff that was lovely presented today, that community-based services that bring people into higher levels of service needs will be cut. So data, we should talk about data. I think innovations in data, and help the counties think through ways. I don't know. But I don't think they're going to go on record saying they're going to cut programs. So, yeah.
It would be very helpful to staff to understand the areas around BHSA implementation that are concerning to you. So, for example, cutting peer services. There are conversations out there that suggest that under the BHSA, counties are not allowed to fund peer services. There are other conversations that say they're absolutely allowed to fund peer services, but they're not required to fund peer services. And so if, hearing from the commission to say, not just as part of this innovation conversation, but part of the broader conversation where we asked Deputy Secretary Welch to, help us drill down into some of the issues, we could certainly help to clarify at least what the law allows, what the law requires, and where there may or may not be incentives, including, peer services, particularly recognizing the investment the state has made in getting to peer certification. We'd want to understand whether or not that momentum is lost, right? We have, as I mentioned, we have had some informal conversations with counties around their priorities on this transition. We've sort of asked what gives you the greatest anxiety and how might the innovation dollars help create some clarity to address at least the unknowns or put a game plan in place. We have not, however, done that formally with CBHDA, and I think that would be, in terms of the question of how, that Commissioner Danovich, Commissioner Rolette, that you talk about, that's, per your direction, that's what we would do. We've had similar conversations with the administration around, if there's a wish list to really think about this transition, what should be on that list. Data has certainly come up. We have spent a lot of time with our staff and our team working on data. The state has legacy data systems, some of which are should no longer be legacy, and this is an opportunity to revisit, particularly if we can eliminate some of the unproductive data gathering and reporting requirements and streamline. You may recall that in our own accountability strategy based on community involvement, we identified funding, services, and outcomes as 3 domains. We built a data system to report out on all the services that are available, and we literally had to retype based on faxed and mailed hard copy reports. So, we'd love to have a data system that, maybe reflects the 1990s rather than the 1960s. But if we could get to the 2020s, I think counties would benefit, right? The goal would be to dramatically reduce the costs of these systems while fundamentally enhancing the utility for counties themselves primarily, but including the communities they serve, but also for the state. So data systems is one of the topics that has come up in our, again, informal conversations.
Toby. Sorry. No, you're good. Commissioner Bench, please.
So Toby, looking at it looks like these are upcoming proposals, and there's a multi-county collaborative on psychiatric advanced directives that's for 4 years. Would that fit under the substance abuse, FSP, or housing? And if not, then how do we work with them to, I almost say, can we make it fit under one of them? Or is that what you're talking about, and using the extra innovation funds? I mean, why are we approving something that's not going to fit under the new BHSA?
You asked a specific question about psychiatric advanced directives.
Well, because it's on the...
Yeah, so, that fits in I'm looking at it. That fits in every category. The project is testing an app to get people real-time preferences and treatment preferences and crisis intervention preferences when they're interacting with law enforcement, hospitals, and peer supporters will be testing the model in these counties, and those should be billable Medi-Cal services, which is what I'm pitching, and we're asking DHCS to provide the project with more guidance relative to that. But I believe that what this project is testing is a modality that can be used throughout the whole system of care and support people in crisis and treatment and strengthen therapeutic alliance and support.
My question wasn't necessarily about that specific one. I was just saying, why are we approving innovation plans at this point that aren't necessarily going to fit under one of the categories?
So that is the question that we're wanting to engage on, right, as it influences staff analysis of the plans that come before you. In other words, we have always asked, how do you plan to sustain this? Now we're asking, how do you plan to sustain this under the new spending categories? So we want to alert you to that, right? And we may also ask, as you think about this transition, is this more important? Is this a greater priority than understanding how you're going to survive under CalAIM, right? We're not suggesting, the commission is not in a position to tell the counties how to spend their money, right? It's more of, as we do technical assistance and we engage with them, how can we help them, inform them of the kind of analysis, of the kind of questions that commissioners ask, including, so we're wanting to today kind of, put on a pedestal that question that these counties will come to the commission in 30 days, be prepared to answer that question, right? And you can imagine a scenario where they might be launching a brand new program that isn't necessarily covered by one of the categories, or they may not be able to stand up, per Commissioner Rollette's comments, because they're so focused on the transition, right? And that's where that sort of prioritization comes up.
Additional comment. I would direct staff to ensure that anybody who is presenting a proposal to the commission for consideration, that they address the question, how are you going to sustain the effort? And then the other subtleties are, I would certainly, maybe naively, believe under the commission's purview to advise them, have you looked at other considerations given behavioral health reform in 2026? That would be my advice for staff, because, again, as a specific example, if someone presents an innovation proposal, one of the commissioners is going to ask the sustainability question. And if they're not prepared to answer the sustainability question, the likelihood of a proposal passing, and I think that there becomes some more strategic advisement. You could talk to them about that.
Thank you, Commissioner. I mean, that is exactly the concern that we have had, is that if we did not have this conversation with you today, that counties may be caught off guard in 30 days. The other piece is we have been very successful in facilitating multi-county investments in collaborative learning. And this is where we may have some opportunity. In some cases, we have put up small amounts of funding to support planning for that, under the argument that it is very hard if planning costs $50,000 and there's 5 counties, they can't use their money to support everybody else. It's really hard to get 5 counties to fund $10,000. We put up the $50,000 to hire the consultants to get things going, or 100. I think the cap has probably been $100,000 in these kinds of instances. And so an additional opportunity is to identify some areas where you all have concerns, and to direct us to talk with the counties and see if we can actually facilitate ways in which they can learn from each other and support each other, because that can often be harder to do because of the ways in which, the cycle of local planning, the local engagement process. And so when the commission signals its interest in those topics, so advanced directives is one of those projects, early psychosis is one of those projects. Solano County had a phenomenal community engagement strategy that we then actually provided funding to help other counties replicate. So it may be presumptuous on my part to suggest that in addition to just informing them of the need is the idea that the commission may lean in and actually try to facilitate in areas of particular concern. To you, but also to the counties, because it's their money, right? And they're coming to you for approval.
So I would just say, lean into that and say that's sort of where I was landing. We want to encourage the counties to be smart about this, right? And be prepared, think it through, answer the right questions, and offer them, if they're not sure, we have options as well that they might consider, and just work with each one accordingly as we're building a bridge, because this is a short-term problem. It's going to go away in a few years. So there's no wrong answer here, right? So let's just feel our way through it together.
Thank you, Commissioner Carnevale. All right. So, Toby, I think you've heard kind of what we've all been saying, that we need to come to a way to be able to work with the counties, make some recommendations as to what we've heard here today, talking about how we really do want to see something that's going to be able to dovetail into supporting them work successfully with BHSA integration. So if you could put something together for us that we can go back and make sure that we have a consistent message to the counties, that they can do that successfully with innovation. Any other comments, questions? Did I add everything that kind of said together?
I just had a silly question, but this is not on this thing, what you said before. And I was reading, what happens after 5 years?
With innovation funds, you mean?
Yeah.
So the design of the innovation component is that a county would use those funds to try something, and if successful, would incorporate that strategy into their MHSA plan.
I was referring to the new law. You were talking, this was like earlier, like, so you were saying we have 5 years with $20 million, right?
Oh, the $20 million a year for innovation that comes to the commission?
Yes.
Yeah.
What happens after the 5 years? Does it go back to the legislature? Like, because there's not you said it was like we have the option to get the money. Do we have to go to the governor, the legislator for the money? Where are the count? I don't understand that.
So so the way the statute has read for the commission since the MHSA was passed was that the state admin component, which was 5% and now is going down to 3%, right? Now recognize that the amount of money coming in is vastly larger today than it was when it started. So even though it's going down to 3%, there's, over time, as the MHSA grows, the actual amount of money may stay the same. So our budget is determined every year by the legislature. Prop 1 said we're going to dedicate $20 million a year for innovation to the commission after 5 years, and then we'll revisit that and see, and the legislature and the governor has the option of canceling it, sustaining it, or even growing it. There is a provision in the statute that also allows the commission to repurpose Mental Health Wellness Act funding as innovation funds. And that Mental Health Wellness Act funding, again, was not in the statute originally. It was a budget proposal from the legislature, and it is ongoing. So it is also subject to revisiting every year. And so
Does
arguably,
that fund?
$20 million.
That fund is $20 million too, the mental health wellness?
Those are the funds that we're currently dedicating to FSPs.
Okay.
Peer
Those are
respite.
not okay. Oh,
That's
okay.
right. And so the idea is if you want to continue to use those funds towards the Mental Health Wellness Act, which is broad, but not as broad as innovation, you can. And so you arguably have $40 million a year. After 5 years, the legislature may decide we do not want to continue to invest. We're not satisfied that the $100 million paid off. Let's repurpose that for something more important. You would still have the $20 million in Mental Health Wellness Act funds, assuming that that aspect of our budget wasn't changed.
This is so great. Sorry if you guys knew this. Is there a performance matrix that the legislator will use? Like, if we do good, is it ambiguous? Like, so if we perform well, is it like performance-based? Like,
I was thinking of all kinds of humorous things to say. So, no, it's a wonderful question. It's a wonderful question. And so we'll talk to you a little bit about that in the strategic plan conversation in terms of our own metrics. But California's budget, we practice something called baseline budgeting, where your budget sort of, rolls forward every year unless it's actively reduced or actively increased. There is no performance requirement sort of designed into the system. But absolutely, the governor and the legislature take into consideration how effectively dollars will be used. And so the language in Prop 1 regarding this $20 million signals the opportunity to talk with them about increasing those dollars after 5 years. And we could actually talk to them earlier than that. Now is not the time, given the budget deficit and the newness of the BHSA. But the whole idea behind that actually is to move that towards more of a performance-based strategy rather than an automatic funding strategy.
Commissioner Gordon, please.
Yeah, so that was a question that I had. So this proposition is subject to change at any time by the legislature? The elements of it? For example, if it seems like more money than 4% or whatever it was would be helpful for workforce development, can that be changed by the legislature? How does that work?
So there's a couple of pieces in there. So there is a provision in Prop 1 that allows changes, recognizing that there may be aspects of it that over time we learn should be modified. It wasn't envisioned in the conversations that we were involved in that topic was on the table. And the legislature has always been, and it has at times, increased funding for different areas even in the MHSA, right? And so there were new workforce investments that were not driven by MHSA dollars, right? And so there is a level of flexibility, both in terms of making statutory changes to the MHSA. I honestly don't know if it would extend to that level of changing those percentages. During the history of the Mental Health Services Act, I will share with you that when it was originally written, it said 5%, it said up to 5% for state administration. Up to was the key. At some point, because the legislature was not allocating 5%, they were averaging about 3.5% for state operations. Anything that wasn't spent for state operations was passed on to the counties for local assistance. Over time, they modified the MHSA to reduce the state admin from 5% to 3.5%, and then they increased it back to 5%. So we would have to get some legal guidance on whether or not that, if they wanted to reduce the amount. But if the issue is putting more money into an initiative like workforce, the state has often done that. Typically, it is used general fund, though, to augment the revenues that are driven by these percentages.
Yes, please, Commissioner Rolette.
Today, we heard two counties talk about the timeframes associated with their 3-year plans. And the thought came to mind that they might think about, if advised by the commission, how to integrate innovation into the development of a 3-year plan. And so that's a specific idea and suggestion that might ameliorate some of the stressors that counties are experiencing.
Yes, thank you, Commissioner.
Yeah, absolutely. Okay, no other comments or questions from my fellow commissioners? At this time, I'm going to ask members of the public, they may request to make a public comment on agenda item 6 by clicking the raised hand button on your computer or the app, or if calling in by phone, pushing *9. Are there any public comments, Amariani? Please raise your hand now as the queue will be closing.
We have one public comment. We have it from Stacy, or I'm sorry, actually we have 2 public comments. The first one is Stacy. You can go ahead.
Thank you. Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I would urge the commission as well as the counties to, the commission, not to just talk to CBHDA and the counties, but also to BIPOC and LGBTQ plus communities through their CBOs, or even through your own committees, the Client and Family Leadership Committee and the Cultural and Linguistic Competence Committee. Innovation funding was very important, not just to BIPOC and LGBTQ communities, but also to the consumer community. I know, because we wanted these programs to serve us and to utilize organizations that were run by our communities. I wanted to make it clear that with these remaining funds in the in-between time, REMCO is not opposed to counties spending the remaining innovation money instead of on a program that cannot be continued to PEI programs that might be cut. But I did hear it mentioned that about CBOs and trying to get them to become Medi-Cal eligible. Well, yes, many CBOs want to become Medi-Cal eligible. I do want to make sure the commission understands that many do not want to become Medi-Cal eligible because they don't have the capacity to become, or more importantly, they don't want to become Medi-Cal eligible because it would require them to change the way they provide services. And we don't hear that often enough. Again, I don't want to discourage. There are some that want to become Medi-Cal eligible, but there are problems with that. So I just want to caution. I know this conversation is supposed to be on this remaining time, but frankly, Remco and others are looking forward to when innovations becomes under the administration of the OAC. Frankly, we were disappointed that more programs serving BIPOC and LGBTQ plus communities were not created under innovation at the county level, although I want to make some notable exceptions such as Fresno County. We are hoping that the OAC encourages or spends innovation funding on CDEPs. And we look forward, we really hope that there is a very public and robust stakeholder process when you start developing how you're going to roll out innovations. We look forward and will be very willing to help you recruit, etc. Thank you.
Thank you, Stacy.
And next we have Richard. Your line is open. You can go ahead.
Hello, everyone. I want to echo what Stacy have stated. I fully support the statements that she have made to the commission, but I want the commissioners to be aware of, it's even though Proposition 1 passed, it is true the programs will be cut. It is true the peer support services will go away because it is not included in Proposition 1 when 2026 comes. That is a reality, and that's a negative impact. That's why I stated earlier to Stephanie, because she needed to hear that the peer workers, peers are not being valued, are not being respected at the state level. They're totally focusing on wellness coaches, on community health workers, and yet leaving us completely out of the picture, not being included. This was a fact that occurred and happened when they were prepping for Proposition 1 with their cramped public hearings that they had and picking selective audiences and excluding peers and peer workers as part of the process because they already made up their mind, their intent to exclude us. So the commissioner needs to stand with peers and peer workers and support peer programs. MHSA could have expanded the ways the state of Oregon did with their peer programs, peer services, yet it never happened with the commission. We have very small peer-based programs that's serving their communities because it's about the unhoused community, it's about the BIPOC community, it's about all communities being served in their recovery and their support and their independence when it comes to receiving peer services. We're not being respected at the state level. Thank you.
Thank you, Richard.
That was our last virtual comment. We just received one from in the room. Floor, if you would like to go up.
Hi, good afternoon. I'm Flora Youssef-Yantarani from Orange County. I'm actually the Innovation Manager in Orange County. I want to thank the Chair and the Commission for this conversation today. It's actually very much on track with what we want to propose in Orange County, which is as we move into Proposition 1, we know we need to reimagine our system. We know we need to take this opportunity and really help our county transition into it efficiently, effectively, and in a way that's going to really help our community and our programs. So one of the things that we'd like to do is bring forward a proposal with 5 different components, each with really the idea of redesigning our system. And so I just want to ask the OAC staff and the commission for your support in helping us with, a proposal of that sort, because it will be a large one, right? It's not going to be easy changing and redesigning the system. And so a large proposal of that scale is coming your way, and we would appreciate any support that the staff can offer us for that. So thank you.
Thank you, Flor.
That was our last public comment.
Thank you, Mariani. So at this time, given what I had talked to, or what I had mentioned to Toby about working together with staff on this, Commissioner Rolette, if I may, I would invite you to work with staff, if you would work with staff to develop a game plan for the final phase of MHSA innovation dollars, and just work with the staff to develop that, if you would, sir.
Be glad to do it, and the comments that were made were in line with some of the thinking that I had that were made by the representative for Orange County. My apologies, I don't remember the name. Flora, thank you. Flora, we're very much in line with some of the thinking that I had, and so be glad to do it.
Excellent. Thank you so much, Commissioner Rolette. And I invite any other commissioners who would also like to work with Commissioner Rolette and staff on that. So please just let us know. Thank you so much. And with that, we are going to go ahead and move on to item number 10. Kendra Zoller, Deputy Director of Legislation, will provide a brief overview of the legislative priorities the Commission will be considering today and introduce our 4 guests who will be presenting on those items.
Thank you. Good afternoon, everyone. In the interest of time, I'll get right into it. We have 3 bills to hear and discuss today, starting with Assembly Bill 2352 by Assemblymember Irwin, it's regarding psychiatric advance directives, and it is sponsored by Kieran Sahota, who is here to tell you about it. Please go ahead.
Thank you. Good afternoon, Chair and Commission members. My name is Kieran Sahota. I am the lead project director for the multi-county, I love the title, the Mental Health Services Act Psychiatric Advance Directive Innovations Project, better known as the PADS Project. First, I'd like to thank the Commission for approving the initial phase of the PADS project back in 2021, where 7 counties created one of the most collaborative projects I have ever been able to be a part of in my decade of work with MHSA. So I do thank the 7 counties for their collaboration. The voices of our stakeholder family members, peer community, first responders, and hospital staff participating in the project seek to change how we respond to behavioral health crisis and how we can use a PAD to reduce recidivism in hospitals and jail settings, while also providing best care to individuals using their own predetermined preferences. AB 2352 recognizes a standalone PAD as a document that reduces stigma of a behavioral health condition. It creates accessibility and inclusion for all individuals, acknowledges the need for digital transformation and the role of a trusted outreach worker or peer support specialist in facilitating and witnessing this document. The bill will allow the use of a standalone PAD in a behavioral health crisis situation, expanding its use beyond the healthcare setting. This is a crucial aspect to AB 2352, emphasizing the importance of reducing recidivism of incarceration and hospitalizations through personalized care and sensitivity, and underscoring the potential impact of a standalone PAD on improving outcomes for individuals experiencing a behavioral health crisis. The project looks forward to the continued collaboration of our counties and stakeholders and moving into the next phase of live testing, where we hope to welcome even more counties to join this truly innovative and collaborative project. I would like to thank Assemblywoman Irwin and her staff for the dedication and support of the PADS project and PADS with AB 2352. I thank you for your time, and I do ask for your support for AB 2352. Thank you.
Thank you. Questions or comments from fellow commissioners?
Yeah, we're going to do the motion at the
Sorry,
very
thank
end,
you.
so we'll go through them unless there's comments or questions.
Okay.
Can you just speak very briefly just to the mechanism of the directives and how they would be utilized and to accomplish these goals?
So the wonderful aspect of the digital technology is that has been the missing piece. PADS have not been utilized for over 30 years. And so really being able to utilize that digital aspect, one of the items that we're looking at is a connection with CLETS, the California Law Enforcement Telecommunication System, as that immediate access for law enforcement, but also based on the consent of the individual. The really neat aspect, and I do hope we can actually do a presentation at some point, is that an individual can choose that consent. What information is given, who gets to see it. And we really are looking at that as an avenue for law enforcement, crisis teams, 988 potentially, and then obviously the hospital EDs. And so really being able to look at the ability in the digital world is you can fill out as much or as little as you want, whereas a paper pad is a challenging document in which you're carrying around potentially 30 pages of paper. So the nice thing about the digital aspect is it can follow an individual. So if they live in Sacramento and they visit Los Angeles, then that digital aspect can go with them. Did I answer your question? Okay, thank you.
Any other questions or comments from commissioners? Okay, let's go ahead and move on. Kendra, please.
Adrian and Danny can come on up. All right, next we will hear and discuss Assembly Bill 2711 by Assemblymember Ramos relating to public health approaches to suspensions and expulsions in schools. You may recall we supported the version of this bill last year, so you'll hear a little bit about the changes this time around from the sponsors, Adrian Shilton, Senior Policy Advocate at the California Alliance of Child and Family Services, and Danny Thurikel, Policy Coordinator with the California Youth Empowerment Network. Welcome, please go ahead.
Thank you. I think we have a brief slideshow as well, or no?
Yes, Cody, you can go ahead to the PowerPoint. Thank you.
So while that's coming up, hi everybody, Adrian Shilton. I'm with the California Alliance of Child and Family Services, and we represent nonprofit community-based organizations across California that are serving vulnerable children, youth, and families in public systems. And we are a proud co-sponsor of Assembly Bill 2711. And we also have some other co-sponsors that are not here with us, but we have them up on the screen here. So in addition to Cayenne, we also have Children Now and the California Academy of Child and Adolescent Psychiatry joining us in this important effort. So in terms of our just very brief agenda on the next slide, we're going to just briefly talk about sort of what the problem is that we're trying to solve and what the data shows about disproportionality in terms of who is being suspended and expelled right now and why that's so concerning. And then we'll talk briefly about what the bill actually does.
Okay, next slide. And so our coalition is looking to reduce substance use among youth, as well as ensure that they receive the supports and services that they are asking for. Data shows that when youth use substances, there are long-term negative impacts and can lead to long-term use of substances throughout their entire lives. In Cayenne's engagement with transition-age youth throughout the state, we've learned and heard from them that they aren't just using substances to use them, there are underlying reasons for them. And so we share a quote with one of the youth that we have worked here with in Sacramento County that really talks about the underlying reasons, coping with stress and anxiety. Their home and school life plays a significant role in that, in their reasons for using substances. Next slide. And so you might consider how our schools are looking to address substance use among youth. And there is no current standard process for making sure that our youth are getting those services and supports. But what is happening is that our youth are being punished for it. Education code gives them the discretion whether or not to suspend or expel youth. And that discretion is actually applied unevenly and is actually counterintuitive to what a lot of our youth are talking or asking for. There is a lack of information and resources available to them. There is no direct engagement with youth, and there isn't a lot of empathy or support or understanding for youth who are dealing with these challenges. Next slide. And so just quickly going over the data on how this discretion is being used unevenly, we see that the suspensions and expulsions heavily impact socioeconomically disadvantaged youth, heavily with males, heavily with our BIPOC community, our Black, Hispanic community, foster youth, and homelessness. And so our bill really hopes to reduce this uneven distribution and making sure that we have a standard process throughout California to make sure that suspensions and expulsions are used equitably, and that services and supports are being delivered to them. Next.
And so in terms of what the bill actually does, this really represents a shift in how the schools are responding to our substance use crisis among our kids, and really represents a shift toward support and instead of discipline. And so what the bill would do is require that schools have to first offer supportive services in the instance that a student is caught on campus with possession or using or is under the influence of a controlled substance. So typically the first approach, especially for our youth, as Danny was highlighting, our youth of color, our homeless youth, our foster youth, the first approach is one of punishment. And so what this bill is saying is that supportive services need to be offered first, and that schools need to document those attempts. So we've added some accountability measures into the bill as well. And this is currently not a requirement in statute. The language is that schools may document. So we're adding the shall, so they have to document this. And then also another really important aspect of our bill is that students are punished for coming forward, either for themselves or for friends, for help-seeking behavior, in terms of identifying that they have a problem or that their friends have a problem specifically with substances. Because this is what we've heard from youth across the state, is that's often the response. So we're trying to break down the stigma associated with substance use as well. So those are sort of the main aspects. We just presented this bill in Assembly Education Committee yesterday, and we had unanimous support from the committee. It was a 6-0 vote, and we also have a growing coalition of support, including from schools. So actually on the next slide, we have been doing some homework since we set aside our proposal last year and really talking to schools. What is working? What are some of the approaches that you are using? And there are a number that have really risen to our sort of best practice list. And actually our partners at Children Now are in Oakland right now at a forum highlighting Oakland Unified and their approach. And Whittier High School is another school we've talked to, and they've implemented, they're really looking at substance use from a public health lens, and they have seen a dramatic drop in suspensions and expulsions as a result of doing this, as a result of really looking at this from public health and how we can better support our kids. Because there's a great deal of research that really shows that connectiveness to schools actually improves health outcomes. And the discipline, there's really no research to suggest that zero tolerance policies or so-called zero tolerance policies actually deter students from using substances. And this is, again, something that we've heard from the youth who are really driving this proposal. So I think the last slide, we just have our contact information from across all of the sponsor organizations. Again, these are children's advocacy organizations who are really dedicated to improving the lives of kids and families in California. So thank you for all the support last year. We feel that we have a stronger proposal this year. So we're looking to just increase our coalition of support.
Yes, please. Questions, comments? Please, Commissioner Danovich.
Yeah, thank you. Very supportive of this. When I've talked to school administrators about rationales for zero tolerance, including those that are skeptical of them, the rationales all center around creating a safe environment, concern about distribution to other children, protecting children that aren't using. I didn't see that addressed here. How does this deal with the issue of intent to distribute?
So we are not touching sale at all. We are only talking about possession and use. The sale of controlled substances is a different code section, and so we're not going there with this particular bill. It only deals with using and possession. And there was something else I was going to say about your question. Oh, we are not. We're also not taking away administrators' ability to remove a student in that moment if they're actively using or actively under the influence. We're not removing the school's ability to actually remove that student from campus in that day, and not coding that as a suspension. We're actually, the policy committee actually gave us some grace to kind of work that out as the bill moves forward, what we call that. But we're trying, we sort of striking a balance with this bill around like some autonomy for school administrators to deal with like sort of immediate health and safety concerns. So they can still remove a student from campus. We're not totally banning this practice.
Yeah, I mean, and the reason I said distribute rather than sell is because it may have nothing to do with sales, but when there have been fentanyl overdoses and whatnot, in schools, there's often, it often stems from one source. So I think that that's the only source of opposition I could really imagine, to this. And so just having a game plan to deal with that, I think would insulate this against.
Thank you very much for that comment.
Please, Commissioner Gordon.
Yeah, I personally support this very much. My only concern is that for the smaller districts, particularly the very small districts, to say there should be a public health approach is fine, but generally they have very, very few people on site, on scene to handle these issues. So I wonder if there is a thought about some accommodation that can be made to put the onus on other bodies in the vicinity of a smaller school district to be on hand to help execute on this, because I think the process you have is certainly preferable to the exclusion, but I think people need a fair chance to be able to execute it.
I would love some thinking maybe as we could work on some language around that, Commissioner Gordon.
Of course.
Because we haven't really addressed that issue. We have heard that from schools in our conversations with the statewide association.
Happy to
Absolutely.
help.
Okay, wonderful.
Please, Commissioner Roulette.
I'm enthusiastic about the notion of addressing suspension rates in the BIPOC community, and in keeping with that, even school districts that are resourced often have some unique challenges associated with the expectation that they will be able to get their students into appropriate resources or as directed in this legislation. And so the opportunity to be a bit more innovative with strategy and understanding that suspension doesn't work, and it certainly doesn't work in the communities that you identify in your data. The data says it's failing.
Right.
So why keep doing that?
Right.
And then, certainly there are community-defined practices that schools should consider here that are typically resourced in communities that have a wide array of behavioral health services or substance use services. But in communities that Dave identified, again, it's okay, what do we do? We got kicking the kids out of school. That doesn't work. So what do we do? And I want to double down on what Dave said. There is a problem, but the intervention that we're using isn't working. And thinking differently about that that response. And then lastly, I only had a very short stint as a school board member. And I remember thinking about the families that were struggling with this issue and listening to their appeals to please don't kick my kid out of school. Because believe it or not, this is one place they actually have some connection to something. And so I agree based on that, but helping families with coming up with some resource that might not be this sort of standard array of behavioral health or substance use resources is also an important part of that. And that how you engage families more effectively, because we're talking about their kids, has to be part of the thinking and when you do something like this. Because they were the ones that were talking to us as school board members, don't kick my kid out of school.
Well said.
Thank you, Commissioner Rowlett. Please, Commissioner Brown.
So in just looking at the information sheet on AB 2711, I haven't looked at drilled into the bill itself, but is there any mechanism for dealing with repeat offenders? In other words, part of the problem that we've had with the reform issues that have come in with, Prop 47 and petty theft, for example, is you have people that come in again and again and again and again and again, and there's no additional penalty for that. And I can see, from a school administrator standpoint, if you have a person who is continuing to come onto school, whether it's for personal use or not, the fact is if that person is bringing fentanyl or some other dangerous drug onto school, it's a danger to all of the people in school as well. So how would this address, does this tie an administrator's hands from being able to suspend or expel a student who's had, say, five offenses?
Sure. Well, maybe unfortunately for us, we couldn't put forward a proposal that would have a complete ban on suspensions, expulsions. That was actually where the sponsors, frankly, had started. We wanted to, because again, we're disproportionately suspending and expelling some kids over others. Like there's something happening to some kids over others.
But are those the kids that are continuing to bring drugs into the schools?
What we know, according to the Department of Education data, is that it is kids from socioeconomically disadvantaged backgrounds, kids of color, boys of color, homeless and foster youth. Like these are the populations that, one, we work with, one, that we care so much about, two, that are just being disproportionately impacted. There's nothing like in this bill now that we have in print, the schools can still, an approach can still be suspension or expulsion. They still can do that. What they have to do first is have a conversation about what is happening with this kid, what do they need, what resources do we have on campus, off campus, with community-based providers who are doing
And I'm
this.
wholeheartedly in support of that. It's just I'm looking at the one that becomes a chronic issue, which is not only is the problem or issue that young person, it's the safety of the other kids in school. But you're saying that there is a mechanism that will allow for that, and you're comfortable with that in terms of the ability to do it? Okay, thank you.
We had to kind of strike a balance on that to allow for that, allow for the suspensions, expulsions.
Commissioner Bunch, please.
I just want to say I strongly support the bill. One of the things I was wondering about, though, if there's anywhere to add in psychoeducation for the children and the families. I was thinking of the quote that you had initially where someone said that all these drugs were being used on campus. And as a parent, I think most of us would maybe not know about that. So I'm wondering if there's any way to add in a psychoeducation piece.
We very well could. We actually are amending a code section which lists different support that can be offered, including substance use prevention, treatment, mental health counseling. We've actually added some things to that code section. We didn't specifically call out what you're talking about, but we absolutely could do that.
Commissioner Chambers.
Can I ask a question on your research? And I guess it's to your point, Commissioner, well, not your point, but just your questioning. I want to know, are the demographics that you just described, Black, boy, male, socioeconomic, are they using more drugs than white kids?
No, that's actually the data that we were highlighting in our PowerPoint in the first couple of slides shows that basically drug use across race and ethnicity is equal. But what is happening is there's disproportionate punishment to these populations. And that's what we really dug into with the Department of Education data.
Home run.
Oh, the obvious, right? I'm a sociologist, but do we know, have they gave any like indications as to why that demographic is being targeted more?
If I could, I would think it also reflects kind of like why are Black and brown males filling our jail systems. I mean, it's the same thing. I think you could correlate the same thing. So it's the same thing that's happening in our schools. It is disproportionate, and that's who that's who they point out and pick out.
I definitely agree with you. I guess I was to the point of repeat offenders, and the disproportion. I just was trying to figure out I don't know. I'm gonna think through this, but I'm happy that you're trying to address that, and it's a first step in trying to address, I guess, structural racism relative to substance use. And hopefully this has some data attached to it so we can see what outcomes are. I don't even know if we could even measure your baseline data. Yeah, I think this is awesome. I just think about myself, my 14-year-old self, onset of mental illness, smoking, and luckily I was in other supports, but definitely my other, some of us didn't make it. So yeah, appreciate it.
Thank you, Commissioner Chambers. And I appreciate you bringing up structural racism. I think we need to always, whenever we can, bring that up where it's relevant, and here I think it is. Also, I have a question and comment. Absolutely support this. And one of the things I think it's also important that as we talk about this in schools, we also talk about the quality of the programs too. Because, I mean, come on, you remember back in the day, pop in a video and, just say no. Let's keep talking about quality. So if we could, and when it prohibits, where it says here, prohibits a pupil who discloses their use of tobacco, tell me please, why did we just stop at tobacco? What about, they're smoking weed, right? And is that just because that's where we got more support? Let's start with something. I'm okay with that. Is that kind of the thinking?
We tried to have the controlled substance language in there.
Even alcohol, if they admit to that, so please.
Tobacco, vaping, and alcohol are the three. We tried to get controlled substance to be part of that, and in the committee process and amendment process, we could not get that through the chair.
Okay, all right. So that was my question, but yes, absolutely do support this. It's where we go. And I know there is currently an ed code that we should be finding other means of correction, but this requires, which is a whole, changes the game. So thank you for lifting this up. Very much appreciate it. Any other, please, Commissioner Montrager.
What obligations does it impose upon schools to be a provider of service or to identify service providers? Because we know, especially in the rural north, there's not a lot of SUD youth treatment providers anywhere. So
yeah,
talk a little bit about
Sure, that's a great question. We leave that open to schools in terms of how they arrange for these services. It could be, school services themselves, school staff themselves, or it could be through partnerships with community-based organizations or the counties, or, we're hoping this is going to spur discussion at the school level about what are the resources out there in community? What do we have here? Because again, we have, in our networks alone, have community-based organizations in every county in the state. And there are other provider associations too that are doing this work now, or who want to partner, or who are actively contracting with schools now. So we're hoping we can sort of look beyond the walls of the school to look at what resources do we have locally that we could bring in to support these kids. So we leave it where it's silent in the bill in terms of how schools actually arrange for the support.
Does it imply that they pay for services?
Not necessarily, not necessarily. They could be referring out to like, a Medi-Cal program, like, a community-based organization that has a contract with their county to do Medi-Cal services for kids. So not necessarily, if it is school staff, then that would be a cost for the school, absolutely. So we'll have to deal with the fiscal implications of this as we move this bill forward.
Okay.
Thank you. Any other questions or comments on this? Okay, Kendra, we can move on to. Thank you so much, Adrian and Danny. Appreciate your time here.
Okay, last one, we have Senate Bill 1318 by Senator Wahab regarding youth suicide crisis response in schools, which will be presented by Carson Knight, legislative aide with Senator Wahab, which should be on Zoom. And we have Amanda Dickey, Executive Director of Government Relations at the Santa Clara Office of Education. Welcome, and please go ahead.
Thank you. So I'm Amanda Dickey. I'm the Executive Director of Government Relations for the Santa Clara County Superintendent, Dr. Marianne Dewan. And I'm proud to be here as a co-sponsor of this bill. Other co-sponsors that are not here today include CTA, the California School Nurses Association, the California School Psychologists Association, and the California School Counselors Association are all of our co-sponsors. We have a lot of other supporters in addition to that. And then, yes, as Kendra mentioned, we have Senator Wahab's staff here as well to answer questions. I want to start by thanking the Commission for your leadership when it comes to focusing on youth mental health, in particular, youth mental health integrated in schools. I don't know if you fully recognize how much schools appreciate your work, the reports that you've done, the focus that you've put on youth mental health. We believe, speaking on behalf of the Education Coalition, that your work has been fundamental to pushing forward many of the initiatives from the administration. So I want to take a minute just to thank you all for that work. This bill is relatively straightforward and simple. It essentially would require, so as you may know, California, I think it was in 2019, required schools to put into place student mental health crisis policies. And as part of that process, the Department of Education was required to create a model policy. Unfortunately, because of the pandemic and because of deadlines to create that policy, a model policy came out without sufficient consultation with stakeholders in the field. And that model policy, unfortunately, in its current form, calls for 911 to be contacted when a youth is experiencing a mental health crisis. It's like step 2 in the process. And I think we can all recognize, everyone in this room, that when youth are experiencing, or anyone is experiencing a mental health crisis, the best option for them is a mental health specialist to support them. And that's what this policy would do. It would require the Department of Education to revise their model policy to specify that when a youth is experiencing a mental health crisis, that youth should be referred to a mental health professional. It's really that straightforward. And I'll just mention very briefly what inspired us to bring forward this bill. We have a student wellness advisory group for the last 3 years who's helped us set up in Santa Clara County 19 wellness centers on district campuses. And one of those students, who was our chair in 2020, I believe it was, and is still actively involved as my intern, actually, in the Government Relations Department, has shared with us a really upsetting story of what happened to him in Santa Clara County, where he confided in a school administrator that he was suicidal because of abuse at home, and that administrator followed the policy at the time, which said, call 911. So she called 911, and the police arrested him and took him away and committed him. And that was despite the fact that the police had been informed. The reason he confided around his suicide ideation was because he and his sister had contacted the police with allegations of abuse a couple weeks before, and the police had been dismissive of those allegations. So it really inspired us to kind of dig into what happened, why did that happen, and how do we make sure that it never happens again. And I'm happy to answer any questions that commissioners may have about the bill.
Commissioners, comments or questions, please? Okay, I see no questions or comments at this time.
Great.
Thank you so
All
much
right.
for being here.
Seems straightforward then.
Commissioner Brown, please.
Thank you, Madam Chair. I'd like to add one more piece of legislation for consideration for our endorsement today. That is Senate Bill 1472, which just got out of Senate Public Safety on Tuesday. This is the bill that has been proposed as a result of a suggestion that was actually made to us at a public comment period a while back. It is legislation that would establish a do not sell list for firearms that people could place themselves on voluntarily. And there is currently no mechanism for that, either at the state or the federal level. This is a bill that would allow a person to put themselves on and to take themselves off that list on their own volition. And the benefit to this would obviously be if someone is having suicidal ideation and in a moment of clarity recognizes the potential for them to carry out a purchase of a firearm and use that in a suicide. This would stop that, would be a mechanism to stop the sale of that firearm. It passed unanimously. It is co-sponsored. Well, it's sponsored by the California State Sheriff's Association. I brought it to the sheriffs to seek an author, and co-sponsored by the California Association of Psychiatrists. And the author is Senator Monique Limon. And happy to answer any questions if anybody has any about it.
Once someone takes them or puts themselves on the list, is there anything required to get taken off?
Is there
Anything required? I mean, do you just
No,
go in and
it's-
say, I want to?
It's voluntary. It's voluntary on and off. And the reason for that is that there'll be significant opposition to it. I think if there was to be some mechanism, there'd be costs involved in that. We've had discussions with the Department of Justice, and we're looking at a very economical way of doing this, because anything that has any kind of significant money attached to it is going to be dead on arrival for the next couple of years, probably, in terms of legislation. So this is something that we're doing there. And there are 3 other states that have laws like this, states of Washington, Virginia, and Utah. And there's no exact way of knowing, but in the state of Washington, it's been in effect since 2019, and they have just under 100 people who have put themselves voluntarily on this list and who remain on that list. And if we extrapolate for California's population, that could be a figure of around 500 or so people that this could impact. And we believe that a lot of lives could be saved by employing this.
It sounds similar to, I think, I don't know if it was a bill, but when we were doing the gun violence, where people could go and hand in their guns.
It is, yeah, there's actually a law that allows for people to bypass the traditional transfer requirements for firearms to take firearms into safekeeping if someone is suicidal. And they ask, or the person asks them, would you hold my guns for a while? The same way at the shooting ranges and at firearms dealers, there's a piece of legislation that requires them to hold for at least a period of time firearms in a storage capacity so we can take them away from. And it's the same notion. That was the whole idea is to make sure that a person who is having suicidal ideation doesn't have access to firearms.
Any other questions? Any other questions or comments regarding this? Commissioner Brown, I just have a question.
Sure.
And please, this is just, excuse my ignorance. Who is the holder of the list?
The Department of Justice. So in other words, right now, when you go to, if you go into a gun shop to buy a gun, you fill out paperwork for the state and the federal government. The state requires you, they run a background check on you, and there's a waiting period. You can't pick up the gun for 10 days. But if you, if in the background process you come up with any number of different things, conviction of a previous felony, a certain type of misdemeanor crime, if you are the subject of a court order or a restraining order, what have you, if you've been committed for mental health exam, that sort of thing, it will trigger a do not sell message to the dealer. And in essence, this would do the same thing. It's a separate, but it's part of what's called the prohibited persons list, so they're not permitted to purchase a firearm. And this allows somebody to put themselves on it so that if that person were to go in and attempt to purchase a firearm, it would come up, no, that they couldn't do it.
Got it. Great. Thank you.
Just real quick, I don't know, just a real quick question, just for more clarity. Did the law just change that you can't buy guns at gun show? I mean, it's illegal, because you can get a gun at a gun show without the waiting period still, right? Or no, is that not in California?
Not in California.
Oh, other
There have
states,
been
right?
other states where there's been a
Oh.
loophole, but that's been illegal in California for many years.
Okay.
Okay, so we are going to go ahead and move on to, I see no other comments from commissioners. We are going to move on to public comment on agenda item 8. So at this time, members of the public may request to make public comment by clicking the raise hand button on your computer or the app, or if calling in by pushing *9. Once the public comment period for this agenda item starts, we will close the public comment queue. So please make your request to comment now. Are there any public comments? Please raise your hand now as the queue will be closing. Mariani, please open the line for public comment on agenda item 9.
Okay, we currently have
10.
four virtual comments. The first one we have is from Marika Collins.
Good afternoon, Commissioners. My name is Marika Collins. I'm the Director of Public Policy and Advocacy with D.D. Hirsch Mental Health Services in LA. We're one of the 988 centers operating in the state of California. I want to it sounds like it's a no-brainer, but I just want to add my words of encouragement to ask for your support of Assemblymember Ramos's very important bill, AB 2711. It's long overdue in terms of taking a public health approach for those providers such as D.D. Hirsch working in the field, in the schools. We cannot be doing anything that's going to further, worsen, their conditions. We need to support our students that are struggling with a whole host of issues. And, as many of you know, once you start expelling, the ability to get them back into school and graduating diminishes. And it is an issue of disproportionality as the data shows. And so I really do hope you support this bill. In terms of Senator Wahhab's bill, I'm just reviewing it now, and I would love to talk with the author's office. I'll reach out to you. I do want to make sure that if you're referencing 988 as a resource, which it certainly would be for students and the school communities in particular, that we're referring to the 988 crisis counselors, because that is another resource that we're promoting through the CDE and obviously across the school districts and the LEAs. So thank you very much for your time, everyone.
Thank you, Marika.
Next, we have Deb Roth. Your line is open.
Good afternoon. Deb Roth with Disability Rights California. I work on mental health policy. I'm a person who lives with serious mental illness, and I'm here to talk about AB 2352, Psychiatric Advance Directives. As your packet notes, DRC and Mental Health America of California oppose this bill. We actually want to get to a support position, but so far, despite substantial amendments brought about largely from our advocacy, the bill is still not peer-friendly in key areas. Before I get to that, though, I want to point out an excerpt from the Innovation Project's materials. In describing legislative and policy advocacy, the project says consumer voices will be in the lead to create a legal structure to recognize and enforce PADS. That has not happened. Consumer voices are not in the lead. And although I am a member of an ad hoc legislative advisory committee for the bill, I did not receive the bill language before it was introduced. Now, the bill's proponents have not articulated how they intend PADS to be used in a crisis. What are law enforcement, first responders, and hospitals supposed to do? What are their obligations? Law enforcement has never had access to an advance directive. So there is much work to be done. And while we appreciate the meetings we've had so far with Kieran and also with Toby and Rachel to work through some issues, we hope this collaboration will continue, but what I'm going to ask you to do is support this bill, but with a direction to formally partner with our organizations and other interested peer groups. Happy to answer any questions. Thank you.
Thank you, Deb.
Next we have, sorry, one second. We have the phone number ending in 837. Your line is open. Oh. The phone number ending in 837.
Hi, this is Mark Carmetz. And the question I have was very similar to the person that had from D.D. Hirsch, and that is why has the 988 number been used with regards to referring for services for the suicidation? And if not, why not?
Mark, you're cutting in and out. Are you there? Do you hear us?
Yes, I do.
Go ahead, Mark.
Okay.
Mark?
I think he was done. Okay. We'll move on for now. We have Stacy. Your line is open. You can go ahead.
Thank you, Stacy Hiramoto with REMCO, the Racial and Ethnic Mental Health Disparities Coalition. I was not going to make comments on 2352, but I thank Deb Roth for waiting to testify because now I will take a closer look. I want to thank the Commission for considering AB 2711 by Assemblymember Ramos, and I want to thank the Alliance and the other sponsors of the bill for not giving up after last year and working so hard to get this passed. REMCO strongly supports this bill. As noted in the presentation by Adrian and in the analysis by the Assembly Education Committee, children of color are disproportionately suspended and expelled from schools. This was already very obvious and known to members of REMCO, but there are many reasons for these disparities. But AB 2711 would be a step in the right direction, not only for children and youth of color, but all youths who struggle with substance use disorder or addiction. The shift in going from punishment first to offers of treatment first seems very reasonable and frankly humane. In my remaining time, I really want to take this opportunity to thank and commend Kendra Zoller for her willingness to meet with and share information with people in the community. REMCO has been facilitating a forum since 2007 where representatives of government and community, both at the state and local level, gather to discuss any policy issue related to the MHSA. Since her hire, Kendra has been willing to attend these meetings and share information that is very helpful and is very much appreciated. I believe it's important for the commissioners to know how Kendra embodies and models the spirit of the MHSA. Thank you.
Thank you, Stacy. Mariani, any more?
That was our last comment.
Okay, thank you. And none in the room, yes? We're good?
No, none in the room.
Perfect. Commissioner Rolette,
I
please.
make a motion that Kendra gets a raise.
Second that motion.
All right, first and second, you heard that, Toby. Make that happen. Okay, so at this time, then we are going to move to entertain motions per legislation. So we are going to begin with AB 2711, that the commission supports AB 2711 and directs staff to communicate its position to the governor and the legislature. So 2711 is
The public health approach to suspensions and expulsions in schools.
Thank you. So I would need a motion and a second.
Motion.
I'd like to second.
I'll second.
I second. So we have, was that, okay, Commissioner Danovich made the motion. Chair Madrigal, second. And Maureen, if you could call the vote, please.
Yes. Commissioner Bontrager.
Aye.
Commissioner Brown.
Aye.
Commissioner Bunch.
Aye.
Commissioner Carnevale.
Aye.
Commissioner Carrillo. Commissioner Chambers.
Aye.
Commissioner Shen. Commissioner Shen. Commissioner Cortese. Commissioner Danovich.
Aye.
Commissioner Gordon.
Aye.
Commissioner Mitchell. Commissioner Robinson.
Aye.
Commissioner Rolette.
Aye.
Vice Chair Alvarez. Vice Chair Alvarez. Chair Madrigal Weiss.
Aye.
The motion passes.
Great, thank you, Maureen. Maureen, we are getting feedback from your microphone. So Maureen, it's okay if I could ask you to mute your microphone. I'm going to have Toby go ahead and call out commissioner names. If you could call out the commissioner names and you'll tally over there. Perfect. All right, excellent. Thank you, Maureen. So motion passed, yes? All right. Okay, so we are going to move on to the next item. I would entertain a motion on SB 1318, that the commission support SB 1318 and direct staff to communicate its position to the governor and the legislature. I would ask Kendra that you remind us what that is.
That is regarding the mental health crisis response in schools.
Okay,
So moved.
thank you. That's Commissioner Gordon. And a second, please.
Second.
Thank you, Commissioner Rolette. Toby, if you could please take roll.
Commissioner Bontrager.
Aye.
Commissioner Brown. Aye. Commissioner Bunch.
Aye.
Carnevale.
Aye.
Carrillo. Chambers.
Aye.
Commissioner Chen.
Aye.
Commissioner Cortese. Danovich.
Aye.
Gordon.
Aye.
Mitchell. Robinson.
Aye.
Rolette.
Aye.
Alvarez. Madrigal Weiss.
Aye.
Measure passes.
Thank you, Toby. Maureen, passed. Thumbs up? All right.
Right.
Moving on. Okay. So we are now moving on to, sorry.
Either the Senate Bill 1472 that Commissioner Brown added.
No, let's make that one the last one.
Make that one the last one. So we are doing Assembly Bill 2352 by Assemblymember Irwin related to psychiatric advance directives.
Okay, thank you. So we are asking that the commission support it and direct staff to communicate its position to the governor and the legislature. I do want to add here, though, before we support it, I would ask the support of my fellow commissioners. I would like to ask that Commissioner Chambers provide guidance to the staff as we engage on this, and that we make sure that we are working with disability rights groups as well, that we ensure that as it goes forward, it empowers peers and supports recovery, that we're really intentional about the language on this bill. I would ask that if we could add that to it, and with that, then I would feel comfortable asking this commission to support it. So if you could document that then, Kendra, and then.
Yes.
Thank you. At this time, I would ask for a motion from my commissioners. Do I have a motion?
I make a motion.
Thank you, Commissioner Chambers. And do I have a second?
Second.
Thank you, Commissioner Bunch. We have a motion and a second. And Toby, please call roll.
Bontrager.
Aye.
Brown.
Aye.
Bunch.
Aye.
Carnevale.
Aye.
Carrillo. Chambers.
Aye.
Chen. Cortese. Danovich.
Aye.
Gordon.
Aye.
Mitchell. Robinson.
Aye.
Roulette.
Aye.
Alvarez. Madrigal. Alvarez, aye. Madrigal Wise.
Aye.
Motion passes.
Thank you. Maureen, motion passes. Got it. Okay, saw your thumbs up. We're good. All right, and now to our last and added legislation. Kendra, number, please.
Senate Bill 1472.
Thank you. The one that Commissioner Brown asked for us to support. And do I have a motion to support it?
So moved.
Thank you, Commissioner Carnevale. And do I have a second?
Second.
Thank you, Commissioner Carnevale. Second. So I would ask at this time that we take a vote.
Just to clarify, Commissioner Carnevale made the motion. Commissioner Gordon made the second.
Sorry. Yes, that's right.
Bontrager.
Aye.
Brown.
Aye.
Bunch.
Aye.
Carnevale.
Aye.
Carrillo. Chambers.
Aye.
Chen. Cortese. Danovich.
Aye.
Gordon.
Aye.
Mitchell. Robinson. Roulette.
Aye.
Alvarez. And Madrigal Wise.
Aye.
Alvarez, aye. Motion passes.
Thank you. Motion passes. All right. Thank you so much. Kendra, thank you. Your raise will be reflected in your next paycheck.
Make a note that Chambers and Roulette made that motion, Chair.
All right, just one more thing. I'm going to hand it over to Toby, please.
The last item on the agenda is a staff report on the strategic plan. Given the robustness of the conversation this morning around Prop 1, per the chair's direction, we're going to bring that up at another time. But I would ask you to take a look at the materials that we provided. The direction from you was to develop a strategy for us to provide periodic reports on the progress we're making against the goals outlined in the strategic plan. And so staff spent some time thinking about key metrics that we could use to report out the impact that we're having. Some of those are pretty explicit. Some of those are very aspirational. And so, if you get a chance, we know that it's been a long day, But please take a look at the materials that are in the packet, because when we come back, the goal is to reflect what we think we've heard from you in terms of our ability to share with you progress against the very explicit goals that are in the plan. So thank you very much for your time today, and look forward to seeing you next month.
Thank you, Toby. And so with that, this meeting is adjourned. I'm going to go home and celebrate my 26th anniversary. So, honey, I'm coming home. Take care, everyone.